neoplasms and histiocytic and dendritic cell neoplasms in part A, whereas in part B it covers B cell and T cell lymphoid proliferations, NK cell proliferations. Apart from that, stroma derived neoplasms of lymphoid tissues, and there are other genetic tumor syndromes. So in this introductory part, we will just see there are two important things like the myeloid proliferation and B lymphoid proliferations, because these two entities, they constitute maximum of the hematolymphoid tumors in our day-to-day practice. So what has evolved in this 2024 classification? So we see, as we move forward from 2008 to 2022 and 2024, so there is an upsurge in the molecular data, and based on the molecular data, the classification of the hematolymphoid tumors, it has been refined, and the newer entities, they have been introduced. So in today's era, what we actually do, so gone are the days of the morphology, but the morphology is very important and very initial stage. So based on which, so you will take further decisions as to which IHCs you have to put, as to which CD markers you have to put on flow cytometry, and with these two findings, then you have to have a molecular and cytogenetics investigations to come up with a complete full-fledged diagnosis. So this is the latest WHO classification. So it incorporates these three things: morphology, immunophenotyping, and molecular or cytogenetics data. Now there are two things for PGs, these are important. So in WHO classification or WHO fascicles, there are two terminology which has been there. So there are like essential criteria and there are desirable criteria. So essential criteria, so they are a must, whether it is on morphology or say at the molecular or cytogenetics level. So if you have to define any particular hematolymphoid entities, so these essential criteria, they are the must. So they must be present. In addition to that, there are desirable criteria where say you can, they may be present, they may not be present. So this is the basically two things which you need to focus and consider: the essential criteria and desirable criteria. Secondly, you also need to differentiate between the entity NOS versus NFC. So NOS is not otherwise specified. So we should not use this terminology not otherwise specified unless and until we have excluded all the existing entities of the WHO fascicles. If we have excluded all those entities and the pathology which we are seeing, we are not able to categorize with the best of the information available, with the best of the testing available, we classify that particular entity as not otherwise specified. Then there is not further classified. So here comes the limitation. Suppose if you have a particular lymphoma, say for example B cell lymphoma, and you don't have the availability of the cytogenetics testing, the molecular testing, and you have limited number of IHC panels. So you have to stop there. You just say that it is a large B cell lymphoma, not further classified. That means we don't have the resources to further classify it. So this distinction is important, and then that it needs emphasis. Then the diagnosis. So diagnosis of any hematolymphoid tumor. So it is based on the lineage. The lineage is determined by immunophenotyping or flow cytometry, and it is coupled with the clinical and anatomical findings and the biological findings. That means the genetic and cytogenetic findings. When all these three things are combined together, then we come to a definitive diagnosis as far as the hematolymphoid tumors as per WHO classification is concerned. There are certain terminology which one needs to be aware of. So this is so whenever we describe any fusions, So the fusions we have to denote by putting 4 dots. That's 4 dots as in it's in a square form. So you can see, so this is a PML RALA fusion. So we should not use the dash between the two fusions. So there has to be 4 dots. So that indicates the fusions. And the terminology, like say wherever there is a C dot, C stands for the genetic code. So wherever there is a DNA sequence code which is there, so it is denoted by C. So whatever is written, say for example BRAF C dot 179T replaced by A. So this C stands for the genetic coding. Likewise, if you have P stands for protein. So we all know the molecular dogma. Say we have the DNA, then the DNA translates into RNA, and then RNA is then transferred into the protein. So P stands for the protein. So P dot val 600 group, that means valine is replaced at the by glutamine at 600 position. So this is in nutshell what this WHO classification speaks about. So you have different lineages. So first you have the hematopoietic lineage. From there you may have lymphoid lineage. You have myeloid lineage, and apart from that, the criteria like say essential, desirable criteria that we have discussed, the clinical findings and the characteristics that is required, and then the genetic first approach. So most of these WHO classification of hematolymphoid tumors, it evolves around the testing of the moleculars and then cytogenetics data. Now let us see some myeloid. What is the update in the WHO classification regarding the myeloid proliferation and neoplasms? So again there is one entity like say myelodysplasia and myeloproliferative neoplasm. So for PGs again you have to distinguish the two entities. They are quite distinct from each other. So whenever we say myeloproliferative neoplasm, so it indicates either CML, polycythemia vera, essential thrombocytosis. So that we are talking about. So that comes under the myeloproliferative neoplasm. If you talk about myelodysplastic syndrome, so myelodysplastic syndrome, it's a precursor of acute myeloid leukemia, and it will show dysplasia in any of the three lineages, like say WBC, RBC or platelets. So this is important thing for PGs, that you have to distinguish MPN from MDS. Now, as far as the update is concerned, so there is one important update which has come up regarding the CML. So in CML earlier we used to categorize CML as chronic phase, accelerated phase and plastic phase or blastocytosis. So now this accelerated phase is done away. So we have only two phases. We have chronic phase and plastic phase. So this accelerated phase is no longer in use in the recent WHO classification. Secondly, there is refinement in the diagnosis of the chronic eosinophilic leukemia, and the entity JMML, that is juvenile myelomonocytic leukemia, now it is categorized as the myeloproliferative neoplasm. So this is the same thing, the accelerated phase is gone, we only have now chronic phase and blast phase. And in the blast phase, so there are two types of blasts you may see myeloid blast, you may say lymphoid blast. So for calling CML with myeloid blast phase, you have to have 20% at least blast present, and then only you will categorize as a blastic phase or blast phase. Whereas in lymphoid phase, this cutoff of 20% is not required. So if you identified lymphoid blast at any point of time in CML, so it is called as the CML with the lymphoid blastic phase. And say there are therapies available. You all know tyrosine kinase inhibitors. Imetinib is the well-known example of this. And imetinib is just the first generation of the tyrosine kinase inhibitors. There are other tyrosine kinase inhibitors in the second and third generations. They are also available if there is resistance observed in in the first generation of tyrosine kinase inhibitors. Now there are this blastic phase which we had discussed that in CML it has been removed, but in polycythemia vera essential thrombocytosis and primary myelofibrosis. So this blastic phase it is still persisting. So if you have more than 10% blast with these features of PD, ET or PMN, you have the accelerated phase available in these three entities, but it has been removed from the CML. So there are genomic alterations also. We all know BCR-ABL1 gene fusion, which is a very characteristic of chronic myeloid leukemia. And this BCR-ABL1 fusion, it's not only seen in CML, but it's also seen in the ALLs, especially the pediatric B-ALL. We may also see the BCR-ABL1 gene fusion. Then JMML, that is juvenile myelomonocytic leukemia. So it is RAS pathway alteration is seen in these. And for polycythemia vera, essential thrombocytosis and primary myelofibrosis. So we may have JAK2, MPR and CALR pathway alteration. So in nutshell, these are the findings for the myeloproliferative neoplasms. So for polycythemia vera, we have the primary driver as JAK2, which is seen in more than 90%, 95% cases. And the alteration is seen in the RBC series. And for accelerated phase, we have to have more than 10% blast. And for blastic phase, more than 20%. Likewise, in essential thrombocythemia, we will see thrombocytosis in the morphology. The alteration may be seen in either of these three pathways. And the same thing is applicable for accelerated phase, like more than 10% blast, and for blastic phase, more than 20% blast. Same goes for primary myelofibrosis. And here we will see myelofibrosis in the morphology. And in chronic myeloid leukemia, we will see BCR-ABL1 gene fusion. And there are high-risk features which have been introduced in place of the accelerated phase. And for blastic phase, we have discussed. Now, let us see how do we approach any B-cell lymphoproliferative disorder. So, B-cell lymphoproliferative disorder, so they basically, whatever classification we do, be it B-cell leukemia or B-cell lymphoma, so that basically recapitulates the development of B-cell in the bone marrow, and so there are various stages of these B-cells which our speakers they will deal with this in their lectures and then their slide discussions. So in what we see is first the stem cell. The stem cell it transforms into pro B cells, then it transforms into pre B cell, then it becomes a naive B cells. So all these changes they are taking place in the bone marrow itself, and from this the naive B cells then they home the lymph node, and in the lymph node they undergo the transformation, they undergo somatic hypermutation, and the class switching happens. So these B cells then they acquire and then they become memory B cells, and these memory B cells, so part of these B cells they become memory B cells and the other ones they become plasma cells. So basically this journey you have to remember, because based on this journey of the B cells you will classify various types of B cell lymphoproliferative disorders. One important thing, say whenever we are dealing with any lymphoproliferative disorder, is that you have to distinguish between the reactive lymphoid proliferation from the clonal proliferation. So clonal, whenever we use the terminology clonal, so that indicates that it's a neoplasm, and we have to distinguish these two, reactive versus the clonal or neoplastic population of lymphoid cells. This already, as we have discussed, so from the hematopoietic stem cells, these are the various stages of B cell development. And in the lymph node, say in the germinal center, we see two distinct zones. So one is the dark zone, which is a zone of proliferation, and the other one is a light zone. So the light zone is where these B cells they are they undergo the class switch. And based on the predominant morphology, so in the dark zone you have predominantly the centroblast, because the dark zone, it's a more bluish zone, so you will see more primitive looking cells or precursor cells, and then centrocytes, they are more mature cells, so you will see those cells in the lighter zone. So as I have said, the development of the lymphoproliferative disorder of B cell type, so it recapitulates the normal development of B cells. So like whenever there is a proliferation of the precursor B cells, so we may have either B acute lymphoblastic leukemia, or so these lymphoblastic leukemias, they have developed from the precursor B cells. Likewise, from the naive or mental B cells, we may have mantle cell lymphoma. From dark zone centroblasts, we may have Burkitt lymphoma. Light zone centrocyte, we may have follicular or DLBCL, that is diffuse large B cell lymphoma. And if the plasma cells, they become clonal, so we may have plasma cell neoplasms or multiple myeloma. So apart from the normal development, we also have to pay attention to the cytogenetic alteration which is happening apart from the morphology. So if there is a translocation of 14-18 and if it involves the centrocyte kind of cells, so we may have the development of the follicular lymphoma, and in this the BCL2 is overexpressed. And likewise in mantle cell lymphoma, we may have the alteration of the cyclin D1, we may see overexpression of cyclin D1, and based on this, then the lymphoma which develops is mantle cell lymphoma. The translocation over here is 11-14. For Burkitt lymphoma, we have 8-14 translocation, and the MYC gene is altered over here. And for Malt lymphoma, it's 11-18 translocations. How do we diagnose any lymphoproliferative disorder? So this is again very important thing to be considered. So whenever we attempt to classify lymphomas based on FNACs or core biopsies, so it has got its own pitfalls. That means the picture is not entirely representative. So for making diagnosis of lymphoproliferative disorder, it is preferable and it is advised that we have to have a biopsy, preferably the excision biopsy of the lymph node. The advantage of examining the excision biopsy is that we actually study the entire architecture, and if there are any say perinodal infiltration, especially say in cases of T cell lymphomas, so we tend to observe the perinodal infiltration of these atypical lymphoid cells. So it gives us basically the entire topography, and this topography is important in making a complete or a correct diagnosis. Apart from the lymph node biopsy, so immunohistochemistry again plays a very important role. There are battery of IHCs which are required, and this decision of putting IHCs, it is taken based on morphology. So we have to have morphology, we have to have IHC, and this is followed by either cytogenetics or molecular testing for classification of B cell lymphoproliferative disorder. If say there is limited resources which are available, so as I have highlighted, so we have to stop, and then we have to say that only say we are able to classify a high grade B cell lymphoma or large cell B cell lymphoma, not further classified. So we have to stop say at that point of the time. So it's not that say if we have the limited resources, we should not be diagnosing the thing, but at the same time we have to have the understanding and knowledge of the various reactive entities as well as the neoplastic entities, and we should try to categorize and make a correct diagnosis as far as possible. So this is basically the evolution of the B cell lymphoid proliferation or B cell lymphomas. So it basically mirrors the development of B cell, and then you classify these B cell lymphoid disorders. In future, say we may have the RNA single cell, RNA sequencing, and based on it, some more information and additional things they are going to come up. and that will further refine the existing entities or introduce new entities. So that things they are say under consideration. Now let us conclude the introductory remark with an interesting case history. So this is a case history of a 53-year-old male with a history of tobacco and Surti intake for last 10 years. The patient complained of rectal bleed and frequent defecation for almost a year's time. The MRI was done and MRI showed there is an irregular asymmetric wall thickening which showed diffuse restriction involving the rectum, and the lesion extended into anal canal for a length of around 10.2 centimeter and a thickness of 2.5 centimeter. The inferior margin was extending up to the anal verge, and the invasion of mesorectal fat was noted. There were multiple rounded mesorectal and inferior lymph nodes, largest measuring 12 millimeter or 1.2 centimeter were seen. So based on this clinical information and the radiological information, so the first thing which comes to our mind is a carcinoma of the rectum. And likewise, this case was clinically diagnosed as carcinoma rectum T4B and 2 stage. Now, the proctoscopic biopsy was done and the biopsy was reported as feature suggestive of adenocarcinoma. And the proctoscopy when it was done, so the scope could be negotiated and the narrowing of the lumen was identified. The biopsy was also taken from the cecum, which shows active typhlitis, and in the rectum it shows acute on chronic proctitis. And based on this histopathological diagnosis, patient received 4 cycles of Capox regimen, and even say after this these 4 cycles of the Capox regimen, the patient condition did not improve clinically, and patient then presented to Mahamana Pandit Madan Mohan Malviya Cancer Center for further evaluation. So the repeat MRI was done and the MRI showed there is a progression of the disease. This already patient had underwent before patient ended up at Mahamana, though because of non-responding nature of the disease, the patient already had a lab diversion, that means a sigmoid stoma, it was created, and patient came with the stoma back and the condition like this. The slide block review was advised, and then we received the slide and blocks for evaluation. So this is a histopathology slide of the rectal biopsy which was received, and this particular block, so it has received 2 diagnoses. The number 1, as I have said, it was reported as an adenocarcinoma and it had come for us to review. And the second diagnosis from some other center, it was given as a granulation tissue. So the granulation tissue and adenocarcinoma. It's a quite contrasting diagnosis. So what we see over here is this colonic mucosal epithelium surrounded by very busy looking, inflammatory infiltrate. And in between these inflammatory infiltrate, we also see some singly dispersed large atypical cells with prominent nucleoli, and there were certain eosinophils, they were also noted. So based on this morphology, then we applied immunohistochemistry. So any idea, any PG students, any idea about what are we dealing with? PG students, pathology PG students? Anyone? Okay, so we applied this initial panel of IHC like LCA, PAN-CK, SOX10 and CDX2. So SOX10 was put to rule out because it's a rectal lesion. So melanoma is one diagnosis which we thought of with the prominent presence of the prominent nucleoli and all. CDX2 again to rule out the poorly cohesive or poorly differentiated kind of adenocarcinoma, PanSeq and CDH2 both were put. So the result showed that these cells, so they were positive for LCA but negative for the PanCK, SOX10 and CDH2. Then we applied the further panel of IHC, considering them as a lymphoproliferative disorder. So we had put CD20, CD3, ALK, EMA, CD30, PAX5, EBV. So out of these markers, so 23 ALK, EMA, they were negative, CD30 was positive, and PAX5 was characteristically positive, and it showed so heterogeneous weak staining in those large atypical cells, and then focally the cells, they were positive for EBV. So this is the image of the PAX5. I'm sorry, I don't have the image of CD30, but then CD30, you have to believe me, it was diffusely positive in these large atypical cells. And if you see PAX5 here, so the PAX5, you can see these large atypical cells, so they show the weak staining as compared to the fellow or the surrounding B cells, which are showing very dark staining. So and then EBV was put, and then few of these cells they showed EBV LMP positivity. So based on it, this rectal lesion, which was earlier diagnosed as an adenocarcinoma or granulation tissue with proctitis and nephritis, finally it was correctly diagnosed as a case of classical Hodgkin lymphoma in the rectum. So this is still, I have to sign out this case. So these photographs I had taken yesterday evening only. So the lymphoproliferative disorders, they are challenging, not only at the nodal location but also at the extranodal location, and I am sure you will witness such cases in the further slide discussion. So I'll end this talk over here, and I would again say thank you to all of you for patient listening, and I would like to invite to our twin oncology centers in Varanasi, the Mahamana Pandit Madan Mohan Malvi Cancer Center, the maroon building on your left, and Homi Bhabha Cancer Hospital, which is a grey building which you can see on your right. So at Homi Bhabha Cancer Hospital, we are treating our hematolymphoid patients. So all hematolymphoid tumors and pediatric tumors we are treating at Homi Bhabha, whereas all the remaining solid tumors we treat at Mahamana Pandit Madan Mohan Malvi Cancer Center. So that's it. Thank you so much.
Thank you, sir, for that insightful and enlightening talk. We now request Professor Dr. Vatsala Kishore ma'am to kindly felicitate Dr. Shashikant CU Patne sir.
We now move forward to the formal inauguration of the CME. We request our respected patrons, Principal Sir, Colonel Dr. B.K. Prasad Sir, Medical Superintendent Sir Dr. Avtar Narayan Singh Sir, Chief Guest Professor Dr. Vijay Tilak Sir, and Senior Faculty Dr. C.P. Mishra Sir, Dr. Neeraj Sir, and Dr. Vatsala Ma'am to kindly come forward for lamp lighting and recitation of Saraswati Vandana.
Okay, how are you?
Sir, good morning. Very nice to see you. Sir, यहाँ पे okay.
तुषार
शङ्करा प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्म विचारसार परमा आद्या जगद्व्यापिनी वीणा पुस्तकधारिणीमभयदाम् जाड्या अन्धकारापहाम् हस्ते स्फाटिकमालिकां विदधती पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्
To formally inaugurate the academic proceeding, we request our respected Head of Department, Professor Dr. Neeraj Singh sir, to kindly deliver the welcome address. We welcome you, sir.
Good morning, respected members. Good morning, very warm welcome to you all. It is a matter of great pride for me and satisfaction for me as head of department to welcome you all in this continuing medical education program on recent advances in medical inquiry class 26. Your presence reflects a shared commitment towards academic excellence, lifelong learning, and advancement in the patient care. The field of hematolymphatic pathology has witnessed unprecedented growth over the last decade. What was once largely morphology-driven now evolved into a complex, multi-layered discipline demanding a deep understanding of immunology, cytogenetics, and molecular biology with targeted therapeutics. In this rapidly changing landscape, the responsibility of the pathologist has become more critical than ever. We are no longer passive reporters of a disease, we are active partners in the clinical decision making. The primary objective of the CME is to strengthen the diagnostic clarity and promote rational integration of advanced techniques and enhance the clinical pathological correlation. Especially in hematolymphatic neoplasm, where precision directly impacts the survival of the patient. Through expert lectures, live slide sessions, and interactive discussions, we hope to reinforce not only knowledge but also the diagnostic confidence. We are extremely fortunate to have with us exceptional faculty comprising of stalwarts who have contributed immensely to academics, diagnostic and research. Their willingness to share the experience, insight and practical wisdom is what which is truly elevates this academic platform. I take opportunity to express deep respect and gratitude to our chief guest, Professor Dr. Vijay Tilak, whose lifelong dedication to hematology and pathology has shaped not only generations of students but faculties alike. His journey stands as a reminder that academic excellence is built on discipline, integrity, and sustained curiosity. To the delegates and young pathologists present here, today I would like to say, question, observe, discuss, reflect, let this CME be not just a transfer of information, but a meaningful academic exchange that inspire better practice and deeper understanding. With these words, I once again welcome you all, wish this CME a productive, insightful and a memorable academic journey. Thank you and have a wonderful scientific day ahead. Thank you.
Thank you, sir, for those warm and encouraging words. May I now call upon Dr. Soumya ma'am to introduce the esteemed chief guest of today's CME, Professor Dr. Vijay Tilak sir.
Thank you, Mavra. And a very warm good morning to everyone. All the dignitaries, our patrons, co-patrons, and all the senior faculty members. So it is my proud privilege to invite a towering personality in the field of hematology, a teacher, a mentor, a visionary who has shaped generations of pathologists, Professor Dr. Vijay Tilak sir, who is the chief guest of today's CME. Sir is distinguished professor at the Department of Pathology, IMS BHU, and has been the organizing chairperson of Hematocon 2025. And I was proud to be a part of it. It was there in Lucknow. He is also the founder president of Uttar Pradesh Hematology Group and Kashi Hematology Group. Sir is also a fellow of Indian Society of Hematology and Blood Transfusion. With over 6 decades of academic brilliance, it reflected in more than 60 publications. Sir has edited multiple books, multiple hematology textbooks, and has organized and successfully mentored several national and the regional conferences. And his contribution to the hematology is exemplary. A former head of the Department of Pathology at IMS BHU, Sir is also the founder, editor-in-chief of the ISHBT newsletter. And his journey is an inspiration marked by leadership and lifelong dedication to the field of hematology. Sir, your presence adds immense academic value and grace to this scientific gathering. May I now request our chief guest for today's event, Professor Dr. Vijay Tilak sir, to kindly address the gathering. We welcome you, sir.
So, a very good morning to all of you. A very good morning to all of the dignitaries present in this hall. I wish to congratulate Dr. Neeraj and this entire department for that endeavor of organizing the first hematology meet. In fact, from the year 2016, I've been trying that Heritage Institute should start CME programs, conferences in hematology. But somehow those efforts did not bear fruit. But I did not leave the things there. I kept on getting in touch with the successive head of the departments, kept on telling them, so let's organize the things. And I'm so happy that finally today, Dr. Neeraj and his team have been successful in organizing this meet. If you want to organize a small meet or a big meet, the efforts are tremendous. You have to really work very hard, and I really congratulate you, Dr. Neeraj, that you have been successful in doing it. And my request to all of those who are present here is that let's join hands with each other and let's cooperate with each other in organizing such meets in the near future. Organizing meets is a tough job, and let's coordinate with each other. And I had already offered Dr. Neeraj that you could include Kashi Hematology Group, the Uttar Pradesh Hematology Group, and since I'm also a joint secretary of the ISHBT, involve them, and that would be a two-way process. It will be beneficial for your department, and it will also be beneficial to the ISHBT. You will get a very wide platform to advertise whatever you're doing. Whatever help you want, that will be available. And now since I'm also the editor-in-chief of the newsletter of ISHBT, and we have resoluted that all those conferences and seminars that are organized under the aegis or by the ISSBT will be covered in the newsletter. That means, say, your conference is being organized or under the aegis of ISSBT, automatically it will get a coverage in the newsletter and it will be circulated throughout the length and breadth of the country. So my request to Dr. Neeraj would be that in future, obviously I like the status of this conference to grow. Let's join hands with the Kashi Hematology Society, and you are already a scientific secretary. Dr. Ila is already in the scientific committee. So let's join hand. Let's join hand with the UPHG. Let's join hand with the ISSBT, and you get a very big canvas from day one. With these few words, I thank you once again for inviting me as the chief guest. Thank you very much.
Thank you, sir, for your inspiring words. We now request the Principal Colonel Dr. B.K. Prasad, sir, to kindly felicitate the Chair, Chief Guest, Professor Vijay Tilak, sir.
May we now also request our MS sir to please come to the dais and felicitate Professor Vijay Tilak, sir. May we now invite our respected principal sir to address the gathering.
Dr. Neeraj, Professor and Head of Department of Pathology, all the other faculties in the Department of Pathology, our Honorable Chief Guest Dr. Tilak, as introduced one of the illuminating academicians in the field of pathology, all our respected guest faculties, my dear students, I extend warmest welcome on behalf of Heritage Institute of Medical Sciences to the guest faculties, to the other delegates who are present here. CMEs are, like Dr. Shashikant was saying when he was talking about the diagnosis essential criteria and the desirable criteria. So CMEs are not only desirable, but they are essential in the growth of any teacher, any medical teacher, any clinician, and also for the learners, because this is continuous education. It is heartening to see that the department is organizing, and I compliment the whole department for that. Also, it is my good luck that I was here in the morning to listen to Dr. Shashikant, who was the introductory speaker, who took us through the journey of how the modern or recent advances, recent updates, which are ingrained in the diagnosis of hematolymphoid disorders, and ending with a fantastic, fascinating case of extranodal Hodgkin's lymphoma. So if I was not here, then I wouldn't have been enlightened like this. This is the benefit that all of you are going to get, all of us are going to get. So thank you very much, and I wish each one of you a very benefiting CME in this hematolymphoid disorders. Thank you.
Thank you, sir, for your words of encouragement. We now request our esteemed Chief Guest, Professor Dr. Vijay Tilak, sir, to kindly felicitate the Principal, sir.
We now begin the scientific sessions. We request the chairpersons, Dr. Anju Bharti ma'am and Dr. Santosh Pandey sir to kindly take their seats on the dais. Dr. Anju Bharti ma'am is an accomplished academician currently serving as an associate professor in the Department of Pathology at IMS BHU Varanasi, an eminent pathologist and dedicated educator. She has over 30 publications, multiple book chapters to her credit. We welcome you, ma'am.
We welcome Dr. Santosh Pandey sir. His key highlights are area of interest with cardio, onco and general medicine with 10 publications and first prize at 65th CSI conference. It is our privilege to invite Dr. Neeraj Dhameja sir, Professor and Head of Department Pathology, IMS BHU Varanasi. We welcome you, sir.
We now request the chairpersons to introduce Dr. Neeraj Dhameja sir, please.
Thank you, Dr. Neeraj and his team for inviting us here. It's my honor to introduce our speaker, Professor Neeraj Dhameja sir. Sir is Professor and Head of the Department, IMS BHU. His educational qualifications are related to his MBBS from Assam University, MD from PGIMR, Chandigarh, PDCC in renal pathology, HGPGMS, Lucknow. He did his DM clinical pathology from Guwahati Medical College and Hospital, Sri Mantra Sankradeva, University of Health Sciences. He was assistant professor on RMS PHU from 2011 to 2017. And his professional experience is he was senior resident from SGPGMIS Lucknow and assistant professor from IMS PHU since 2011 to 17, and he has numerous publications in various national and international journals. Over to you, sir.
Good morning, everyone. Thank you, organizing team, Dr. Neeraj, and thank you, Chairperson. I'm Professor Neeraj Dhameja, President and Head of Department of IMS BHU. So my topic is updates on acute leukemia and its approach. Acute leukemia, we all are familiar in layman's language, it is called as blood cancer and supposed to be a very deadliest disease. We have seen numerous movies made on this topic where it has been shown the pathetic conditions of the patients suffering this disease. But now recently, many progress has been done in both the diagnosis and the treatment of these diseases. Patients can survive and have a normal life. So what is leukemia? Leukemia term was first coined by Rudolf Virchow. He is known as the father of modern pathology. Leukemia word is made of two words, leuk and mia. Leuk means, as we know, leukocyte. It's a white cell. Mia means something in excess in the blood. So when the white blood cell count becomes excessive in the blood, it is called as leukemia in simple language. So now leukemia is defined as clonal malignant hematopoietic disorders resulting from genetic alterations in normal hematopoietic stem cells. Previously, no cause was found, but later on when technology developed, it came to be known that majority of these disorders, they have some genetic alterations. This genetic alteration leads to excessive proliferation with defects in apoptosis leading to leukemia. So excessive proliferation of abnormal cells is called as leukemic cells. Now leukemia can be of two types, acute leukemia and chronic leukemia. As we have seen in the previous talk by cancer, that myeloproliferative disorders. So chronic leukemias come under that group. My topic is acute leukemia. So excessive proliferation of abnormal immature cells, that is leukemic cells, which are known as blasts. What happens as the disease progresses, leukemic cells accumulate in the bone marrow, blood and organs, displacing normal progenitor cells, suppressing normal hematopoiesis, and patients present with different manifestations resulting in anemia, thrombocytopenia, and infective complications. Leukemias are the neoplastic proliferation of hematopoietic cells. Acute leukemias are defined as neoplasms with more than 20% blasts in the peripheral blood or bone marrow. Now, what are blasts? Blasts are immature cells which are defined morphologically as teaching PG students. We define blasts as blast cells with high NC ratio, opened up chromatin, conspicuous to inconspicuous nucleoli, and is can be to moderate amount of cytoplasm with or without granules in the cytoplasm. Now these blasts, they are classified as type 1 blasts without any cytoplasmic granules and type 2 blasts with few eosinophilic granules, also known as granuloblasts. They are also classified as myeloblasts or lymphoblasts. There are three main groups of acute leukemias: acute myeloid leukemia, acute lymphoblastic leukemia, and acute leukemia of ambiguous lineage, where no definite lineage can be assigned to these blasts. So this diagram shows how these hematopoietic cells develop in the bone marrow. So there are hematopoietic stem cells which form colony forming cells, and because of the presence of different types of they ultimately commit to the lineage, and the myeloid lineage, that is WBC, it is defined by, it starts from the myeloblast. Myeloblast develops into promyelocyte, then myelocyte, metamyelocyte, band form, and neutrophil. Similarly, monocyte cells develop, and then erythroblast develop. So this diagram shows the normal development of the hematopoietic cells. So here we can see myeloid cilia, they start from the myeloblast. Myeloblast mature into promyelocyte, then myelocyte, metamyelocyte, ultimately into neutrophils. Similarly, lymphoid cells, they start from the progenitor cells, develop into mature lymphocyte, what we see in the periphery. Now, acute leukemia is defined as when the blast percentage becomes more than 20%. In the peripheral blood or in the bone marrow, it is defined as acute blast. Now, depending on the morphology of the blast, whether they look like myeloblast, myeloblast is defined as cell with opened up chromatin, prominent nucleoli, we may see all rods in the cytoplasm. Whereas lymphoblast is defined as comparatively smaller than myeloblast, clump chromatin, nucleoli is inconspicuous and scanty amount of cytoplasm, and there is no all rod. So based on the morphology, and the morphology has to be practiced by the residents so they get mastery in diagnosing acute leukemia, which is a basic step in the leukemia diagnosis. So based on the percentage of blast and the morphology of the blast, the diagnosis is made. This is acute leukemia supporting myeloid lineage or lymphoblastic lineage. Now, what is our approach to leukemia? How do we diagnose? So first, the clinical features, that is very important. Suppose a patient presents with features of anemia, recent onset anemia. we have excluded other cause. Patient presents with continuous fever which is not responding to therapy and other parameters are negative. Patient may present with bleeding disorders because of thrombocytopenia. Patient may present with pancytopenic features, throat pain, which is a common finding in acute leukemias. Or in the periphery, patient may present with hyperleukocytosis. So based on these features, it is suspected that patient may have hematolymphoid disorder. Maybe this is acute leukemia. Then a peripheral blood smear is examined. This is the first step in the diagnosis of leukemia. Once the peripheral blood is examined, it shows blast. Patient undergoes a bone marrow examination where previously morphology used to be the only modality by which we used to make a diagnosis, morphology with added cytochemistry. But nowadays, because of technological advancement, we have immunophenotyping and we have molecular and cytogenetic testing, which play now a very important part in diagnosis and prognosis of acute leukemia. So now, bone marrow is done. Bone marrow slides are made for the morphology. Sample is taken for the immunophenotyping, that is flow cytometer, and a sample is taken for the molecular diagnostics and cytogenetics. So whenever the resident performs a bone marrow aspiration with a suspected diagnosis of acute leukemia, during the same setting, the resident has to take 3 samples. First is, when the suspected case of leukemia, do the bone marrow, just aspirate at the hub of the needle, prepare the slide, then you take 5 ml of sample from the bone marrow. Take 2.5 to 3 ml sample in the EDTA vial for flow cytometry. Because that is the most important aspect nowadays, which gives us a lineage whether this is a myeloid leukemia or this is a lymphoid leukemia. So that step is very important. 2 ml sample you take in cytogenetics, because cytogenetics gives us information about the prognosis, and cytogenetics decides the therapy of the patient, whether this patient will need bone marrow transplant or patient will have response with the conventional chemotherapy. So these things are very important. But nowadays, because molecular techniques have developed very fast and they also play a role, so we have to take sample for molecular techniques also, especially these are usually done by the PCR method. So a fourth while you have to take extra section for the molecular studies. So while performing the bone marrow, resident has to remember these things. Make slides, good quality slides for morphological evaluation, a sample for immunophenotyping, that is flow cytometer, a sample for cytogenetics, and a sample for molecular techniques. So these are ICMR guidelines that how we have to approach a case of acute leukemia. So these are the basic tests. Simultaneously, these patients of acute leukemia, these tests have to be done. CBC, which is must in every case, LFT, RFT, electrolytes, uric acid, because we have to evaluate patient whether patient may have tumor lysis syndrome or not. And that is an emergency, oncologic emergency. So we have to do these biochemical parameters. Chest X-ray, because ALL, especially T lymphoblastic ALL, they can present as a mediastinal mass. So a chest X-ray has to be done to rule out any mediastinal mass. Bone marrow, flow cytometry, cytogenetics, molecular studies, these are must. Because these ultimately patients will require chemotherapy, and chemotherapy can predispose patients for infective complications. So we have to rule out whether patient is having any viral infection, that is HIV, HPV, HCV. Blood grouping, because these patients will be needing blood support because of anemia. HLA matching, this is a very important aspect because some of the leukemias, they need bone marrow transplant. So while working for the acute leukemia, we have to do HLA matching with the family members, so that once the patient gets response, patient is in remission, immediately we have to go for transplant. So HLA matching has to be done simultaneously. Lumbar puncture. ALL has very high chance of infiltrating the CNS. So in those patients who present myeloid leukemia who have CNS symptoms, and in all patients with ALL, lumbar puncture has to be done to document whether blasts are present in the CNS or not. Then cardiac function evaluation is must because in these patients anthracyclines are used. Anthracycline has a cardiotoxicity. So a basic cardiac evaluation has to be done whether the patient has any cardiac abnormality or not. So this is the way we approach a case of acute leukemia: basic hematological investigations, bone marrow, immunophenotyping, cytogenetics, molecular studies, radiological studies, infective profile, and HLA matching. These are tests which are must in every case of acute leukemia. In 2017, an article was published in the Archives of Pathology and Lab Medicine, and the topic was initial diagnostic workup for the acute leukemias. In this article, the ASH/CAP guidelines, they raised certain questions that before diagnosing a case of leukemia, or what should be our approach to leukemia, then certain questions were raised. First is, what clinical and laboratory information should be available? What samples and specimens should be evaluated? What tests are required for all patients during initial evaluation? What tests are required for only a subset of patients? Where should laboratory testing should be performed? And how the results should be reported? So this is a very nice article published in Archives of Pathology 2017, where they recommended certain guidelines that what should be our approach to the diagnosis of acute leukemia based on these questions, and then certain recommendations, 27 recommendations they gave. Now first is, what clinical and laboratory information should be available. So while reporting a bone marrow, the pathologist should have information about the clinical features, what symptoms patient have, whether patient has no bleeding features, whether patient has infective complications, whether patient has anemia. Physical findings, whether patient has any organomegaly, splenomegaly, lymphadenopathy. These findings or this information must be provided to the pathologist. Laboratory information, the pathologist while reporting the bone marrow should have information about the CBC and the GBP, what was reported. What samples and specimens should be evaluated? Peripheral blood and bone marrow are the most important samples which should be reported. What tests are required for all patients during evaluation? So as we have seen, bone marrow morphology, immunophenotyping, cytogenetics are must in every case. Whereas depending on the scenario, we can go for either extensive molecular test or limited molecular test. Where should laboratory testing should be performed? A reputed laboratory with experience in cytogenetics, molecular techniques, these tests should be performed in reputed laboratory. And then they give how the result should be reported. These are their guidelines, 27 recommendations they have given based on these questions. So based on this evidence, they have strongly recommended these guidelines. Now, what are the clinical features of these patients? Because what happens in acute leukemia, there is abnormal proliferation of blasts which are replacing the mature hematopoietic cells. So mature hematopoietic cells are not produced, these blasts they persist, and because of some molecular abnormality, they have lack of apoptosis, they proliferate and replacing the normal hematopoietic cells. So these patients may present with symptoms of anemia because there is no production of mature RBC. There is absence of leukocytes, mature leukocytes like neutrophils, which are our first line of defense mechanism. So patients may present with infection or fever. That is a very important sign of leukemia. Patient presents with continuous fever. Bleeding, because megakaryocytes are replaced by these blasts which are not produced. So there is a thrombocytopenia and patient presents with bleeding manifestations. These bleeding manifestations can be cutaneous or it can be intra-abdominal or other organs involved. Patient, in sometimes when there is a massive production of these immature cells, that is hyperleukocytosis, patient presents with thrombosis. This is very common in chronic myeloproliferative neoplasm, that is polycythemia vera, where intra-abdominal thrombosis is one of the important causes of thrombosis. So it is recommended that whenever a patient presents with intra-abdominal thrombosis, especially Budd-Chiari syndrome, patient has to be evaluated for chronic myeloproliferative neoplasm like polycythemia vera. Gum hypertrophy. Here you can see image. This is one of the very characteristic feature of acute myeloid leukemias, especially of the monocytic lineage. These monocytic blasts, they have tendency to infiltrate the gums, and patient presents with characteristic gum hypertrophy. So whenever we are evaluating the patient, we have to evaluate all these sites to look for any evidence of gum hypertrophy. Myeloid sarcoma. What happens in myeloid sarcoma? Sometimes these blasts, they accumulate in the extra myeloid sites. It may be lymph node, it may be periorbital area, and they form mass in the extra myeloid regions. This is known as myeloid sarcoma. Now this myeloid sarcoma, it can develop after diagnosis of acute leukemia. It can develop simultaneously with the diagnosis of acute leukemia, and sometimes it may present before the diagnosis of acute leukemia. So we have to consider myeloid sarcoma also, and then in certain conditions like Down syndrome, patients who have Down syndrome, they have high chance of developing acute leukemias. They may develop acute myeloid leukemia, or they may develop acute lymphoblastic leukemia. Acute myeloid leukemia of M7 type is commonly seen in these patients. So these are the clinical findings which depend on the suppression of the series which has occurred and organ infiltration. Now coming to the diagnosis of acute leukemia. As we have seen, CBC is the gateway of diagnosis of acute leukemia. So that is a very important step. It gives us idea about other lineages, what is the hemoglobin level, what is the TLC, what is absolute neutrophil count. So absolute neutrophil count is very important parameter. TLC, when we say TLC, as such does not provide us much information. What we need to know, what is the neutrophil count, because these are our first line of defense. Whenever any infection enters our body, these neutrophils, as medical graduates, we all have learned about acute features of acute inflammation and chronic inflammation, where we have seen what are the cellular and vascular events in acute inflammation. That neutrophils, they are recruited to the site of injury, they eliminate the organism and protect us. So if there is, because of leukemic infiltration, if there is low neutrophil count, these patients have very heavy chances of infection complications. Then platelets. CBC gives us idea about the level of platelet thrombocytopenia and whether patient needs supportive platelet or not. Another very important feature, especially for the residents, suppose you have emergency duty where you are seeing the slide. So you have to evaluate all these parameters. You have to hemoglobin, ANC count, TLC, the DLC. You have to accurately identify the blast. Blast should not be missed. Sometimes it may have difficulty to classify whether this is myeloid series or lymphoid series. That is acceptable, but at least blast should not be missed. Platelet count, we have to manually check with the slide, and then we have to document supportive other documents that whether patient is having features of DIC, because many of these leukemias, they may present with DIC, especially APML. So we have to see whether any fragmented cells are seen or not. So these are the things which we have to see in CBC and GBC, which is our gateway to diagnosis of acute leukemia. Then we have to classify morphologically whether these blasts are myeloid looking or these are lymphoid looking. So as we know, acute leukemia, the definition is general teaching is more than or equal to 20% blasts. And we have to screen for or rods. So we have to see the morphology, always evaluate the cytoplasm, whether you can see the granules or the presence of or rods. And then this represents the morphology. Here we can see in the lower figure, there is presence of or rod, and then these are the blasts. In certain leukemias, where we take into consideration blast equivalents. Blast equivalents are the cells which are the precursor cells in certain leukemias which are taken given as important as the blast. So acute leukemia, blast more than 20%, and in certain conditions, blast equivalents. So what are the blast equivalents? These are abnormal promyelocytes and promonocytes. So these are the two blast equivalents which are considered with the acute leukemia. Promyelocytes in acute AML M3 or ABML, and promonocytes in AML M4 and M5. So these are the blast equivalents. We will see morphology later. So this is the morphology showing different type of blasts. Blasts may have different appearances. They have variations. Classically is high NC ratio, opened up chromatin, conspicuous nucleoli, scanty to moderate cytoplasm. They may have nuclear convolutions. They may have binucleation. They may have nuclear folding. Cytoplasm varies from scanty to moderate. In lymphoblast it is scanty. In myeloid it is comparatively more. Then cytoplasmic color, whether it is a gray. In erythroblast it is bluish in color. Then we have cytoplasmic vacuolations and cytoplasmic granules and organs. So depending on morphology, blasts have variable morphology. Previously, when I was doing my PG 25 years back, then we used to give great importance on cytochemistry. We used to do MPO, SBP and PAS. At that time, there was not very much availability of flow cytometer. Immunophenotype that was in the development stage. Cytogenetics and molecular studies was also very limited. The data was just coming that these patients have recurrent cytogenetic abnormalities, but it was not available. So we used to rely on the cytochemistry, MPO, SBP and FAST. So when dot and block positivity used to be present, we used to call it as lymphoblast. When MPO used to be positive, it is labeled as myeloid leukemia. Then in some cases we used to do other tests like NSE for monocytic leukemias and SBP. So this was the panel which we used to do in all cases, morphology and cytochemistry. But now this scenario has changed. Now the first priority is immunophenotyping so that we get exact idea about the lineage of the blast so that accurate therapy can be planned. And then cytogenetics and molecular studies. This is again cytochemistry. We have MPO, brownish color in the cytoplasm we can see. We have SBP, we have PAS, where dot and block positivity, NSE in cases of AML, M4 and M5. And these tests, NSE was used to be very tough. Suppose I was doing GIASHID, and if my case where NSE, this AML, M4, M5 was suspected, and if I could do this test, it was a great achievement for me that okay, I have done NSE and it has come positive. But now all these things are historical. Now we don't do all these things. But as for resident teaching, the resident should know because you may not availability of all these latest techniques. So you have to be dependent on these facilities also. So this was about morphology, which is our first step in diagnosis of acute leukemia. Next comes immunophenotype. So what are the commonly used antibodies in the one-step comprehensive acute leukemia panel? So there are two schools of thought. One, they say you apply in single setting all the panels so that you can accurately diagnose a case of acute leukemia. Whereas some school of thought, they say that you should have a two-way approach. First you use basic panel. Basic panel gives you an idea, okay, this is the myeloid, this is the B cell, this is the T cell, and then you go for further classification. So what are the markers which we use? So backbone marker is CD45. So what we do, first we gauge the cells based on CD45 and site scatter. So blasts usually they have low CD45 and low site scatter. So this is our backbone marker. Now as the definition says in acute leukemia, these are blasts. And blasts we have seen in the hierarchical order, these are the primitive cells. When the myeloid series develop, the first cell is the blast. So we have to put markers for immaturity. So what are these markers of immaturity? These are CD34, CD38, TDT, HLA-DR for EML. So these are the markers for immaturity. So first, our backbone marker, that is CD45, based on which we will get the blast. Then we will put markers of immaturity. These are the markers of immaturity. Now we have to confirm whether these blasts are of myeloid lineage, monocytic or other lineage. So what are the myeloid markers? Cytoplasmic MPO. This is the specific marker for myeloid cells. CD117, CD13, CD33, 15, 11B and monocytic lineage CD4, CD14, CD11B, CD11C, 36, 64, 65, 66 HLA-DR. Megakaryocytic 41, 61, 42B, 36, B lymphoid CD10, CD19, 20, cytoplasmic 79A, 20. T lymphoid cytoplasmic CD3. This is the characteristic and specific marker for the T lineage. Other markers being surface CD3, CD1A, CD2, CD4, CD5, 7, 8. Plasmacytoid dendritic cell CD123, 303, BCL1A, and erythroid CD235, 71, 36. So this is the panel which we have to utilize, where by utilizing this we can accurately diagnose the case of acute leukemia. This is the basic step. If this is wrong, because now we have clear demarcation of therapy for acute myeloid leukemia and acute lymphoblastic leukemia. If this step goes wrong, the therapy will be wrong and ultimately there will be no response. I have seen patients where the diagnosis was first ALL that ultimately turned out to be, because of absence of some marker, to be AML, and ultimately the therapy was changed. So this has to be very accurate. Now, what is the two-step approach? The two-step approach involves an initial short screening panel for lineage assignment, followed by a second more extensive and detailed panel focusing on the lineage determined by the screening tube. So first you use a basic panel. We have one marker of immaturity, one marker for B cell, one marker for D cell, and one myeloid marker. So based on this, in majority of the cases, we can segregate. And then once we have identified the lineage, then we can go in the second step, more extensive study. The European consortium recommends this strategy. Their screening tube is named acute leukemia orientation tube. It contains 8 antibodies: cytoplasmic MPO for myeloid, TDT 34 immaturity marker, 1979A for B lineage, 7 cytoplasmic 3 CD3 and CD3 for T lineage. Then this is the first tube where we can assign a lineage. Now they go for extensive study for B-ALL, CD10, 20, 38, 58 and cytoplasmic mutation. Then T-ALL, CD1A, CD2, CD3, CD4, CD5, 7, 8 T cell receptors, and myeloid and monocytic CD13, 33, 117, 16, 11B, 14, 64, 36, CD4 and 300. Erythroid 105, 36, 71, 225 megakaryocytes, 61, 41 and 42. Now based on this, in majority of the cases we are able to assign lineage to the blast. But in certain cases where there is a problem or the blast expresses multiple lineages, then it is called as acute leukemia of ambiguous lineage, where we are not able to particularly assign lineage. So that we will see later on. For uncertain lineage situations in the ELOT, they will use more than one second level tubes. So there are two methods for flow cytometry: a single tube exposure or a two-step procedure. It depends on the lab what they prefer, but the European guidelines recommend two-way process. So this is again the markers which we use for this myeloid, T lineage and B lineage. Now next step is cytogenetics. So we have covered morphology, now immunophenotyping. Now the third aspect is cytogenetics. Cytogenetics, as we know, it tells us about the information of our genome or chromosome number. It is seen that cytogenetics or cytogenetic abnormalities play a very important role in the development of these leukemia. There are different cytogenetic abnormalities defined. There may be aneuploidy, there may be trisomies, there may be translocation, or there may be complex karyotype where 3 or more abnormalities are present of different types. So this is very important, cytogenetics. Cytogenetics gives us, because of certain genetic, recurrent genetic abnormality, it can assign a particular leukemia, and it gives us very important information about prognosis. Based on, I will show a slide later on, based on this cytogenetic, we prognosticate the acute leukemia, whether this is of standard risk, intermediate risk, or poor risk. And based on this risk stratification, therapy is planned of the patients. Suppose a patient of acute myeloid leukemia, he falls under the standard risk group. Now in these patients, bone marrow transplant is not required. These patients have good response to conventional chemotherapy, that is intensive chemotherapy, and there are high chances that they will respond to therapy. So that is why the ELN, that is European Leukemia Net, they advise that in standard risk transplant is not required. We don't need, because transplant will be hazardous to these patients, because transplant has its own complications. So this cytogenetic evaluation is very important for risk stratification. Now, here we can see in some of the cases there is trisomy, in some of the cases there is short chromosome, that is loss of material. So based on this, we can identify different type of cytogenetic abnormalities. So these are the abnormalities which have been highlighted, and we can see trisomy in many chromosomes. Then this is 922, which we all are familiar. So it gives information about a specific genetic abnormality, additional complex cytogenetic abnormality, and prognosis. So these are the common cytogenetic abnormalities which are seen in acute myeloid leukemia. It may be normal in 44% of the cases. So they have classified under 60 years and more than 60 years. So we can see almost around 50% patients may have normal cytogenetic scores. So whenever we get a report that patient has normal cytogenetics, it immediately comes under intermediate grade according to ELN criteria. And then we have to evaluate for other genetic abnormalities like FLT3, CEBPA, and NPM1. And now the molecular techniques have advanced very fast, and we have targeted therapy against these markers like FLT3 antagonists. They are really used now in clinical practice. So we have to identify the cytogenetics and the molecular abnormality. In almost 50% it is normal, and in rest of the cases we can see these are the abnormalities: inversion 11 23, inversion 16, translocation 821, trisomy 15 17. And whereas in above 60 years of age group, here we can see almost 47% are normal. Here the abnormalities changes: abnormal chromosome 5 and abnormal chromosome 7. They are more common in elderly population because these cytogenetic abnormalities, they are associated with myelodysplastic feature. And once a patient ages, there are chances of clonal hematopoiesis which can lead to myelodysplastic syndrome. And these myelodysplastic syndrome, they are associated with abnormalities of chromosome 7 and 5. So here we can see these patients, these abnormalities are more common. And then 17p. 17p, we know the p53 gene is located on chromosome 17, which is a poor prognostic marker. Fishman. So fish is further advancement of cytogenetics, where we know that okay, this leukemia has this translocation, and because of this translocation there is a formation of this gene which leads to this protein, so we can detect. So in those leukemias where we know that there are definite translocations associated with particular abnormality, we can go for fish. But fish is not complementary to this cytogenetics. Cytogenetics has to be done in every case, because in fish we can diagnose only those cases where we know the translocation, whereas maybe patient has other translocation or other abnormality which cannot be detected by fish. So fish can be helpful in certain cases, not in every case. So cytogenetics has to be done in every case. Now fish, there are probes are used depending on the translocation. Now these probes can be fusion probe if a partner gene is known, and break apart probe if partner gene is not known. Now depending on the fusion or the break apart probe and the color signal which we get, a particular sample is labeled. Now, what are the somatic mutations? Nowadays, molecular studies have taken a very important role. It has been seen the myeloid neoplasm, they are associated with particular mutation in particular genes. These genes, they range from different segments of our genome. They may be demethylation genes, they may involve the spliceosome and different regions. So the genes which are commonly mutated in acute leukemias or myeloid neoplasm, they are ASX L1, BCOL, EZS2, SF3B1, SRSF2, STAT2, ZRS2 and U2EF1. So these are the myeloid panel which is now commercially available as NGS for myeloid panel to detect mutation in these genes. And because of this NGS, we can identify a specific targeted mutation, as I have said, FLT3. Those patients who have FLT3 mutation, now drugs are available like midostaurin, pirtobrutinib, and once this mutation is detected, these targeted therapies, they are added on the conventional intensive chemotherapy. So this was about diagnosis. What is our approach from morphology? First is clinical features. Patient presents with certain clinical features based on which suspected to be having a leukemia. Then peripheral blood is examined. CBC is done, which confirms that okay, there are blasts in the periphery. Patient undergoes bone marrow, where we assign lineage, okay, acute leukemia, myeloid origin or lymphoid origin. And then accordingly, risk stratification by cytogenetics and molecular studies, and patient is treated. Now, how do we classify acute leukemias? So this classification has evolved from 70s to the present era. Initially, FAB classification was used, that is French, American, British classification. This classification developed in 1976. When I was doing my PG, we used to follow this classification. This classification was easy to use because at that time we had only morphology and cytochemistry. Then came WHO classification. WHO first came in 2004, then 2008, 16 में revision हुआ, and the latest classification came in 22, in 5th edition, which was published in 24. Simultaneously in 22, another classification came, ICC classification, International Consensus Classification. This classification parallels with the WHO classification, and some of the experts are common in both WHO classification and ICC classification. So we will see in detail about both these classifications. So this is the FAB classification. FAB classification, they classified from M0 to M7. M0 was undifferentiated acute leukemia, where M2 was negative. So we have seen that cytochemistry used to play a very important role in diagnosis of these leukemias. So we encountered a bone marrow where the blasts, where we were not able to identify exact categorization, immature cells with high NC ratio, opened up chromatids and some nucleoli, no cytoplasmic or rods of it. Now, whether could this be undifferentiated or whether this could be lymphoid or myeloid, we were not sure. And we used to do MQ in every case. In these cases, MQ used to be negative. To call it as MQ positive, at least 3% of the cells should show MQ positive. So these cases used to show MQ negatively, and they were labeled as acute undifferentiated leukemia. Then came AML with maturation. So here, MQ used to be positive, at least 3%, and the blast count used to be more than 90%. So based on these features, we used to say AML without maturation. Here maturation means when we examine the periphery, hardly any neutrophils or other myeloid lineages cells were seen, and in bone marrow, more than 90% cells used to be the blast. Then came AML M2, AML with maturation. When we used to diagnose this entity, we were very happy. Okay, इसमें कट ऑफ पहले WHO का होता था 30% blast to 89% blast. So we used to, as resident, we used to be very happy. चलो AML M2 लग रहा है 50-60% blast दे. because 90 के ऊपर जा रहा है हमारा कट ऑफ, तो हमारा AML M1 without maturation, और अगर 30 to 89 के बीच में आ रहा है then this is M2. Here these cells they used to be strongly MPO positive, that is more than 3%. Then acute promyelocytic leukemia AML M3. These cells used to be strongly MPO positive. And as residents, suppose those residents who are posting in emergency, if you get a call from the clinician, a patient of 25-30 years has presented with heavy menstrual bleeding or bleeding from any side, and this is the CBC report with pancytopenia. The resident, the quality resident who is seeing the slide, always consider a possibility of APML. Because this is the classic presentation of APML patients. They may present with bleeding from any side. In females, heavy menstrual flow is one of the common presentations. And you see the slide and you are identifying this blast. We will see the morphology later on. And once you immediately diagnose these cases, immediate therapy is planned, and if we give therapy immediately, it has a very good response. And majority of these patients, they survive. So, identification of acute promyelocytic leukemia, especially the morphology by the residents, is very important. You can save the life of a patient. Because if the diagnosis is delayed, therapy will be started later, and by this meantime, patient may develop DIC, because these patients have very high chances of development of DIC. So if immediate corrective measures are not taken, they may develop DIC with intracranial bleed, and patient may succumb to their disease. So this is very important. Then AML M4, acute myelomonocytic leukemia, where some class were myeloid lineage, some class were of monocytic lineage, and they used to be MPO positive, NSC positive, and with fluoride inhibition. Then AML M4 with eosinophilia, acute myelomonocytic leukemia with eosinophilia, M5 monoblastic leukemia, where MPO used to be negative and majority of the blast they used to be monocytic leukemia. Then acute erythroid leukemia, where BAS was very positive, but in contrast of ALL, here they used to be diffuse granular cytoplasmic positivity, whereas in ALL there used to be the dot and dot positivity. Then acute megakaryocytic leukemia, where all the markers were negative. So this was a simple classification based purely on morphology and the cytochemistry. And ALL was classified as ALL L1, L2 and L3 based on the morphology of the blast. Classic L1 blasts, they are classified as small cells comparative to myeloblasts with clump chromatin, inconspicuous nucleoli, and scanty amount of cytoplasm. L2, they used to be differential with the myeloid. They used to be large, opened up chromatin, nuclear convolution, and moderate amount of cytoplasm. L3, what we now know as Burkitt's lymphoma. So it has been separated because Burkitt's lymphoma is a neoplasm of mature lymphocytes, germinal cytoplasm. So based on this morphology, ALL was used to be classified as L1, L2, and L3. Now came 2022 WHO classification. Here, WHO said that okay, leukemia should be diagnosed in collaboration with the clinical features, the morphological features, the immunophenotype, and cytogenetics or molecular techniques. So now this is our comprehensive panel by which we make a diagnosis of acute leukemia. This is the WHO classification. On the left side is the ALL classification. On the right side is the AML classification. So AML, they have classified into two groups: AML with recurrent cytogenetic abnormalities and AML with differentiation. So there are two categories: recurrent cytogenetic abnormalities, and in those cases where there is differentiation to the leukemic cells and maturation, but without any recurrent cytogenetic abnormalities. So in those cases where there is a recurrent cytogenetic abnormality, as we know what we are taught according to WHO, that to call it as acute leukemia, we should have 20% blasts. But in cases with recurrent cytogenetic abnormality, this cutoff is not required. 20% blast count is not required. And there is a molecularly defined classification that APML with PML-RAR fusion, what we used to call it as AML M3 with 15-17 translocation. Now, based on this molecular abnormality, they have pointed out APML with PML-RAR fusion, AML with RUNX-T1 fusion, CVFP, YH fusion, and similarly according to cytogenesis. Here, in all these disorders, 20% cutoff is not required except two of the conditions which we will see here. BCR-ABL fusion and CEV-PA. In these two conditions, still we require 20% cutoff because as we know in CML, what is the abnormality? 922 translocation. And this translocation leads to fusion of BCR and ABL. And where we have seen that previously we used to call it as chronic phase, accelerated phase, and blast phase. But now accelerated phase has been removed with high risk feature they have classified. So here from 10 to 19 we take it as high risk feature. So differentiate from that, they have retained that 20% criteria. So in these two conditions, and it was found that in CPPA mutation, if we lower the cost, it will affect, lower the blast percentage, it will affect the therapy. So in these two conditions, 20% our cutoff is retained. In rest of the conditions, 20% cutoff is not required. So these are the two main headings of WHO classification. AML, acute myeloid leukemia, with defining genetic abnormalities, which we have seen in the previous slide, and acute myeloid leukemia defined by differentiation. This is what we have seen in FAB classification. Acute myeloid leukemia with minimal differentiation, acute myeloid leukemia without maturation, AML with maturation, basophilic leukemia, myelomonocytic leukemia, monocytic, erythroid, and megakaryocytic leukemia. So this resembles like our FEV classification. So now these are the definition which WHO has given how we define by differentiation. So in genetic abnormality, suppose the patient tests positive for A21 or RUNX-T1 translocation. Immediately this is labeled as acute leukemia. Acute myeloid leukemia with that particular genetic abnormality. But here in differentiation, we don't have any such criteria. We don't have any particular genetic abnormality. So we have to define by certain definition. So AML with minimal differentiation. So blasts are negative, that is less than 3% positive for MPU and SBB by cytochemistry, what it was described in the FEP classification. But on immunophenotyping, they express two or more myeloid-associated antigens such as CD13, 33, and 117. Similarly with other classification, AML without maturation, that is more than 3% blasts are positive for MPO by immunophenotyping or cytochemistry or SPP, and they are negative for NSC because NSC is a marker for monocytic leukemia. So these are the criteria which are given for AML defined by differentiation. Now in this classification, we can see acute myeloid leukemia, myelodysplasia related. So this was a new entity which was described here. Earlier, dysplasia was defined based on morphological features. Then they said no, morphology can be subjective. What I think that these are hypolobated or monolobated megakaryocytes. You may not say. You may say no, this is a normal megakaryocyte. मुझे लग रहा है कि रिंग न्यूट्रोफिल है. You may not agree. So this is subjective. So then they came with cytogenetic and molecular definition of myelodysplasia. So how do we define AML myelodysplasia related? By defining cytogenetic abnormalities and defining somatic mutations. What are these cytogenetic abnormalities? Complex karyotype. Complex karyotype, when we identify more than or equal to 3 abnormalities in a particular cytogenetic evaluation. It may be aneuploidy, it may be trisomy, it may be translocation. When the combination of these 3 abnormalities or more than 3 abnormalities we identify in a particular case, this is known as complex karyotype. And this complex karyotype carries a very poor prognosis and comes under poor risk category in PLN classification. Similarly, 5q deletion or loss of 5q, as we have seen, these are common in elderly age group because they have more chances of myelodysplasia because of clonal hematopoiesis. Abnormality of chromosome 7, which may be monosomy 7, 7q deletion, then 11q deletion, 12q deletion, 17p deletion. Then defining somatic abnormal mutations. What we have seen that we have to do the molecular test for identification of these abnormalities. So these are the genes which are commonly implicated in myelodysplasia related AML. So introduction of a mutation-based definition based on a set of these are 8 genes, more than 95% of which are present specifically in AML arising post MDS or MDS MPN. So now what earlier used to be that AML myelodysplasia based on morphology, it has been replaced by cytogenetic and molecular testing. Similarly, I'm sorry, a little bit hazy in this picture. So simultaneously with the WHO came the ICC classification. ICC is similar with the WHO classification because majority of the experts are seen in both the classification. But there are certain differences. They also classify as AML with different defining abnormalities, myelodysplasia related and with differentiation. But there are certain differences between them. This classification is hierarchical based. Means first we have to identify recurrent genetic abnormality. If it is not present, then you go for P53. If this is not present, you go for other. What we have seen, 8 genes mutated. You identify these genes. If these are not present, then you go for cytogenetics. What we have seen. So this is a hierarchical classification. Another very important difference is in WHO criteria in recurrent genetic abnormalities, blast cutoff has been removed except 2 conditions. Here they have retained the blast cutoff. At least 10% blast should be present in the bone marrow to with that particular genetic abnormality to label as acute leukemia. 10 to 19% they say for MDS and more than 20% is your acute myelodysplasia. So according to this ICC classification, they have retained at least 10% blast should be present with definite genetic abnormality. So these are the differences which we will see later on. The major differences are blast cutoff and your hierarchical classification. So here we can see the WHO 5th edition, that is 22, and this is the ICC classification. Here at least 10% threshold blast. Here we have no blast threshold except 2 conditions. So this is about ICC classification, how we go with ICC classification. So first, based on morphology, we identified patient has leukemia, acute leukemia. Immunophenotypic way, we confirmed that okay, this is acute leukemia. Now we went for cytogenetic or molecular abnormality. AML defining recurrent cytogenetic abnormalities we identified, so we go by a hierarchical pattern. So we will label it as AML with recurrent cytogenetic abnormality. Suppose if this cytogenetic abnormality is not present, we identified mutated TP53 with a variant allele frequency more than 10%, VAP of more than 10%. That is very important. If this is not present, then we go for mutated 8 genes which we have seen. Whether these genes, any mutation in these genes is present or not. If it is not present, then we went for cytogenetics, whether the defining cytogenetic abnormalities which have been described in AML are present or not. So we evaluated for cytogenetics. These cytogenetic abnormalities were also not identified. Then we labeled as AML anomalous. Then suppose we have mutated TP53 with a VAF of more than 10%. Then we evaluated the blast percentage, whether this is 10 to 19% or this is more than 20%. If it is 10 to 90%, MDS AML with mutated TP53. More than 20% AML with mutated TP53. Similarly, in other conditions also, blast percentage, we have to correlate with the blast percentage. 10 to 19% MDS, more than 20%, it is leukemia. Then we have to identify certain qualifiers with the diagnosis of leukemia. Whether this is therapy related, suppose patient is a known case of breast cancer. Patient has received anthracyclines and other chemotherapy. After 3 or 4, and this is a routine clinical scenario. We have seen cases Patient was earlier diagnosed with breast carcinoma. Patient took therapy. After 3-4 years, patient presented with hematological symptoms, was evaluated to have acute leukemia. So we have to use adjectives or qualifiers. Whether this is therapy related, whether a patient had a known earlier MDS or MPN, or there is a germline predisposition. So we have to use these qualifiers. So this is in nutshell about the ICC classification. Now, as technology advances, now we are seeing what is happening inside our cell and the blast. So this is the common pathway or intracellular pathway where different genes are involved which are active in these blasts, leading to their proliferation and symptoms of the disease. So here we can see we have FLT3, we have IDH mutation, we have PTM mutation, we have NPM1 mutation, then we have DNMT3, that is arithmetic, and we have menin. So this is very important. So molecular genetics is going to play a big role in near future. Now we have targeted therapy against everyone. FLT3 targeted therapy, midostaurin, vitiquinone, this is commonly used. All patients of acute leukemia with normal karyotype, they are evaluated for 3 genes, NPM1, FLT3 and CEBPA. If FLT3 is positive, patient is given this therapy. Similarly, a patient is evaluated with NGS to look for mutations in other genes. If IDH1 is positive or IDH1 or 2 mutation is present. So now we have targeted therapy against IDH mutation. So with the backbone of the chemotherapy, this targeted therapy is added. Now latest in 24, it has come menin inhibitors. And clinical trials are going on that menin plays a very important role where we can see in development of these leukemia. So menin inhibitors have been developed and clinical trials are going on. So identification of a particular genetic abnormality is going to play a big role in near future. Now a little bit, because as resident, molecular is one thing, genetics is one thing, but resident has to learn morphology. This is the domain of the pathologist and we should be develop mastery in that. So I will go some of the slides of morphology to show you different appearances of the blast in different leukemias. Okay. So this is acute undifferentiated leukemia where we can see we cannot assign any definite morphological features to leukemia. These appear just primitive blasts without further categorization. Okay. And we can see these blasts are negative for MPU. Then AML M1. Here we can see in the left side in A section we can see predominantly there are blasts. So here we can see predominantly these are blasts, but we can see some of the cells showing differentiation like myelocyte. Okay, so with minimal differentiation. Now here we can see some of the cells show MPO positivity. And here, so this is AML M1 with maturation. There is slight maturation and some of the cells show positivity. Then this is AML M2. Here we can see these are the blasts. Some we can see ball rods. We can see some maturation here, and these are the positivity MPO and SPP. So here we can see comparatively more maturation is there with positivity for the myeloid markers. Then AML M3. This is very important. Here we can see what is the characteristic morphology of AML M3. Any resident? Pathology resident? So how do you describe atypical promyelocytes? Any resident can define? So that morphology you have to fix in your mind so that you are not going to miss a atypical promyelocyte and patient is not accordingly treated. So here we can see these are atypical promyelocytes. These are smaller than the conventional promyelocytes. They have bilobed or reniform nucleus with nuclear foldings, cytoplasmic granules, and we see all rods. Multiple all rods can be seen, which are known as HECs. Okay, so this is, and we can see positivity for myeloid markers. Then this is hypogranular variant. So this is a microgranular variant where granules are not seen in the cytoplasm, but nuclear abnormality is present. So you have to identify the. So I will go fast with these slides. Then again a classic APML, and you can see multiple all rods. Then again, here we can see this is the characteristic appearance of the nucleus. So resident should not miss this bilobe nuclei. So this is myelomonocytic. Then this is erythroid leukemia. These are the monoblastic cells. And here in erythroid cells, we can see diffuse granular positivity for BAS. Whereas in ALL, it is dot and block positivity. So now comes, so we have diagnosed a case of acute leukemia. We have confirmed with the cytogenetics, with the morphology, immunophenotyping, and molecular abnormalities. Patient has been labeled as acute myeloid leukemia with adjectives according to classification. Now we have to risk stratify the patient. Whether this has a standard risk, intermediate risk, or poor risk. So this is the ELN risk stratification criteria. So what are the favorable risk factors, what are the intermediate risk factors, and what are the poor or adverse risk factors. So 821 in version 16 mutated NPM1 without FLT3IG and CBAP mutation. So these are labeled as favorable or standard risk factor. Then we have, these are the poor risk factors. Whatever lies in between is known as intermediate, and normal karyotype is usually taken as intermediate. So diagnosis done, risk stratification done. Now our job is to treat the patient. So there are two elements of leukemia treatment: supportive treatment and the definite treatment. Supportive treatment, you monitor the patient for TLS, you monitor the patient for cytopenias, give blood transfusion, platelet count, and anti-infective protocol you give and monitor for TLS. These are the two important components of the supportive treatment. And now definite therapy. So now you classify the patient, whether patient is fit for intensive chemotherapy or patient is fragile, elderly, then we can go for less intensive therapy. So suppose a young patient of 40 years with good performance status, no cardiac abnormality, no comorbidity, and patient has a good family support who can provide him adequate blood and platelet support, we can go for intensive chemotherapy. And the cytogenetics says patient has a favorable cytogenetics or intermediate. So we can go for intensive chemotherapy. The backbone of intensive chemotherapy, we call it as 3+7. 3 days of anthracycline and 7 days of cytarabine. This is the classic backbone of acute myeloid leukemia treatment, but this is very toxic therapy. Post this 7 day of therapy, patient lands up with severe cytopenias with different complications. Patient may have infective complications, severe bleeding, and patient may be critical and may succumb. So before starting this therapy, you have to be very thorough. You have to be adequate with well-trained nursing staff, the doctors, and with all the facilities. But if the patient responds, it has a good chance that patient can recover his disease. So we give induction therapy, that is 3+7, followed by consolidation chemotherapy, which comprises of cycles of high dose cytarabine therapy, 3 to 5 years, followed by maintenance therapy. Now this maintenance therapy, if the patient has poor or intermediate cytogenetic risk factor and there is availability of donor, immediately go for allogenic hematopoietic stem cell transplant. If it is of very standard risk, you don't need bone marrow transplant, continue the maintenance therapy with low dose therapy and follow the patient. If the patient is old or has comorbidity, so now recently newer drugs have been developed, that is hypochondriatic agent and venetoclax. Venetoclax is anti-BCL2, which is a very important drug in AML treatment. So in these patients, we can go for hypochondriatic agents and venetoclax. If HMA is not available, we can go for cytarabine. So and now, but what is the disadvantage of this therapy? These are continuous therapy. Whereas in intensive therapy, you give 1 dose of intensive chemotherapy, follow the patient. If does not respond, go for second dose of intensive therapy, not more than that. Here, every month you have to give continuous therapy. So this is about EML, how we diagnose different modalities in this stratify and how we treat the patient. Now comes AML. So this is the classification, ICC classification. Again, in WHO we have seen the recurrent cytogenetic first we have to assign whether this is DALL or BALL. BALL comparatively has good response to therapy. DALL is
Sorry
considered.
to interrupt, we are running short of time.
These are the different cytogenetic abnormalities. This is the morphology. And these are the cytogenetic changes. In BALL, we have to evaluate patient for BCR-ABL. If BCR-ABL is present, we have to give TKI therapy. So these are the guidelines how we have to evaluate a case of ALL. In ALL, because they have high chance of infiltration into the CNS, we have to do number one check in every case to document the CNS disease. CNS 1, 2, 3, depending on the number of lymphoblasts. And the treatment of ALL is, we have classically pediatric inspired protocols like BNM protocol or hyper-CVD. Again, strategic reduction, consolidation, maintenance, and risk stratification. Where risk stratification depends on initial TLC count, the cytogenetic abnormalities, then mFAST. So acute leukemias of ambiguous lineage and leukemias, where the definition is more than 20% fast, but we are not able to assign lineage, whether it is myeloid, lymphoid, or T or T cell. So this is the classification of leukemias with defining genetic abnormalities like BCR-ABL1, KMT2A, ZNF3A4, or immunophenotypically defined mixed mFAST, B lymphoid, T lymphoid. So these are the class morphologies and how do we diagnose? When we have positivity for B lineage marker, positivity for T lineage marker, and positivity for myeloid lineage marker. If two of these markers are present and their intensity is as high as the background normal cells, we label it as mFAST. So these are the, then there is a European group which has given a story how to we score. If these markers are present, we give 2 points for T cell, these are the markers for 2 points for myeloid. So depending on the positivity of the markers, 1 and 0.5 markers are points are given. Treatment, usually these patients are given ALL type of therapy. Now another, the latest concept in acute leukemia, now we have to follow the patient, MRD. Minimal residual disease is the biomarker used for prognostic, predictive, monitoring and response assessment in the ALL. The two most commonly technologies to evaluate MRD are FCM and real-time PCR, each of which can detect one malignant cell in 10 to the power 4. So other modalities are digital droplet PCR and NGS. Here they are more sensitive, can detect one abnormal cell in 10 to the power 6 of the cells. So and now once we have diagnosed, we have treated, we have to follow up the patient response evaluation. So certain terms which we use is complete remission with partial hematologic recovery, and complete remission with incomplete hematological recovery. Then morphological leukemia-free status, aplastic marrow, refractory disease, progressive disease, and relapse disease. So these are the terms which we use for the follow of the patient depending on the response. So this is.
Thank you, sir, for insightful talk.
To cover the important topics, I think you have understood a little bit. So thank you the organizing team and Dr. Neeraj for giving me sincere thanks to you.
Thank you, sir, for insightful talk. We sincerely thank our chairpersons for your esteemed presence and moderating the session. We also request Dr. Neeraj Dhameja sir to kindly felicitate the chairperson of the session, Dr. Anju Bharti ma'am and Dr. Santosh Pandey sir.
now request Dr. Ila Singh ma'am to felicitate Dr. Neeraj Sameja sir.
We now move to the next scientific session. May we invite the chairpersons, Dr. Vismay Das sir and Dr. Deepa Rani ma'am to chair the session. We welcome you ma'am. We welcome you sir.
Dr. Visvedas, sir, he is currently working as an associate professor at United Institute of Medical Sciences. He has done his SRship from AIIMS Bhubaneswar and has multiple publications to his name, and his field of interest is primarily oncopathology.
Dr. Deepa Rani ma'am is currently working as an associate professor, Department of Pathology, IMS BHU Varanasi. She got gold medal in MD Pathology. She got multiple national awards. Ma'am also received, ma'am is also an editor and author of hematology books, organizing secretary of UP Hematopathology Group Conference.
We are honored to welcome Dr. Zakaria Chaudhary, sir, Professor and Head of Department of Oncopathology, Mahamana Pandit Madan Mohan Malviya Cancer Center and Homi Bhabha Cancer Hospital, Varanasi, Tata Memorial Center.
We request our chairperson to kindly welcome Dr. Zakaria sir. May I request our esteemed chairperson to kindly introduce our speaker for this session.
Very good morning, all of you. I take the privilege to introduce our speaker for this session, Dr. Zakaria Chaudhary. Sir is currently Professor and Head of the Department of Oncopathology, Mahamana Pandit Madan Mohan Malviya Cancer Center and Homi Bhabha Cancer Hospital, Varanasi. Sir has over 7 years of experience in the various aspects of oncopathology, including molecular pathology with active interest in the fields of lymphoma, soft tissue sarcoma, pediatric oncopathology and breast oncopathology. He is a GM oncopathology teacher and ex-member of Institutional Ethics Committee. He is a member of several reputed international and national societies. I request sir to please start the session.
We request the chairpersons to kindly welcome Dr. Zakaria sir. Please come on stage. Sir, please come on stage.
Sure.
So, good afternoon, everyone. And I thank Dr. Neeraj and his team for having me here and allowing me to speak on my favorite one, and that is lymphomas. So, I consider myself an lymphomaniac, but I will not make you a maniac. I'll help you solve the chaos which, when we say lymphomas, and especially for budding pathologists, when we say lymphomas, it creates, it reminds us of this classification which I'm going to show, so many entities, and what then you do with it. So my job here is not to confuse you. I hope I will not confuse you. I hope I can, make things simpler for you. So that's why it's an approach about lymphomas, and that's why I've titled it Lymphomas, Making Sense of the Chaos. So with this, I start with my presentation, and this is the classification of humors. I will be talking on a basic approach, and then maybe put in a few things for senior persons also present in this audience. So it will be like targeted to a budding pathologist, and also some inputs about how you go about lymphomas. So this is the classification of tumors of the hematolymphoid, which we all know. And then comes, I've been more specifically dealing with B and T cell lymphomas, Hodgkin's and non-Hodgkin's, but primarily my focus will be on non-Hodgkin's because the organizing team told me that I have to focus more on non-Hodgkin's, and preferably that's better, because if I talk on Hodgkin's, then it will take one more day. So Hodgkin's, let's leave it for some other day. Let's focus today on non-Hodgkin's lymphomas. Okay, so here you have the classification here of non-Hodgkin lymphoma. Doesn't end there. You go on and you have another big classification, which now, the thing is that Hodgkin lymphomas are here in early classification was a separate thing. It was not under B cell. And now Hodgkin lymphoma has also been brought under B cell lymphoma. So you see the B cell spectrum is expanding and expanding. And you have also the plasma cell neoplasms. So, looking at all this, what do? You get confused. But my job here is to make things simpler to you, and I'll try to do that. So my outline of my talk will be the structure. So when you go about doing lymphomas, you first have to understand the normal histology, normal architecture of lymph nodes. So our structure of a lymph node, architectural patterns, approach and assessment, diagnosis of lymphomas, how we go about differential diagnosis, and the conclusion. So the first thing when I go about cases and when I teach my residents is the diagnosis of lymphoma is multidisciplinary. So before you look at the slide, you should have, number one, the adequate history, and you should know how to correlate the history with the diagnosis. That is the first thing you do before seeing the slide. I always tell my residents, do not see the slide without appropriate history and without correlating and having a set of clinical differential diagnosis in mind before you even start seeing the slide. So I am emphasizing again and again to the budding pathologist, you should have adequate knowledge about the clinical correlation of lymphomas. Have a set of clinical differential diagnosis in your mind before you even start seeing the slide. So that is the first thing you should do before you start doing things related to pathology. You should have the clinical things first. And I request the chairperson to please let me know 5 more minutes in advance when I need to finish. So you look at the clinical features, you look at pathology, biochemistry. Why is biochemistry important in the context of lymphoma? Biochemistry is important in the context of lymphoma because of serum LDH. That is the one and only thing, primarily, which you have to take help from your biochemistry department when you're doing lymphomas. Why I say so? LDH, if it is in thousands, it's very high. It's very high. It primarily indicates a high-grade lymphoma, more so burden. So when I get an 8-year-old child with an abdominal mass and LDH is 2,000 or 3,000, even before seeing the slide, I can tell you it's burden. Right? So that is the clinical context which you need to have. Right? Then you see the radiology. In radiology, a conglomerate, whether it is a contiguous group of nodes or non-contiguous. If it's contiguous, probably Hodgkin's. Non-contiguous, probably non-Hodgkin's. So that is again the radiology with the PET CT coming in. You can have a look at how the SUV uptake is, how much metabolism is there. So you get an idea looking at the SUV uptake also, whether you are looking at a low-grade lymphoma, which usually do not give a high SUV uptake, and whether you're looking at Hodgkin's or whether you're looking at non-Hodgkin high-grade, which will give a high SUV uptake. So that correlation again can come into picture. So you have a person say with generalized deformity, a 60-year-old male, a generalized deformity, specificity finding is telling you if SVR thing is maximum is 3. Now if it's 3, I know without looking at the slide, the problem I'm dealing with a low-grade lymphoma. So that's how you correlate radiology findings in your histology as well. Then obviously the most important section, and that will be your morphology. The morphology is the cornerstone. Morphology is the cornerstone on which you base your diagnosis. Because if you do not are adept in morphology, you will falter in the use of ISC also, right? So that is the important point. And I tell you, most of the diagnosis of lymphoma is based on the HNA section. It is not based on the ISC section. ISC definitely will help you to reach a diagnosis, but what ISCs will you put is determined by your histologic observations. So if I I meet many people who do, who are working in resource constraint setting, and they tell me, oh, we do not have ISCs. No, please don't constrain yourself to not giving a proper diagnosis, or I would say precise, but even a proper working diagnosis if you do not have ISCs. Even if you do not have ISCs in your setup, you can give a proper working diagnosis. Now, what do you mean by that? I mean by that, you may not give a precise diagnosis. Say you will not be able to tell that, okay, this is DL, BCL, double hit type. That's fine. But you can at least tell them that, yeah, it is DL, BCL. If you are adept at histology, you may be able to tell them that, okay, this is looking like a mantle cell lymphoma, not a follicular lymphoma, not a small lymphocytic lymphoma. So that is what I'm meaning by working diagnosis. You can still offer them that even if you do not have ISCs, but you are good in your histologic observations. Next comes the ISC techniques. Now ISC is, I'll go on a slide which talks about ISC. Flow cytometry is more to do with hematologic malignancies, I mean by that, which are liquid forms. So flow cytometry is not very good. I would say that developed till now in the context of solid lymphomas. It's more to do with lymphomas which you are encountering in the blood or bone marrow. Cytogenetics and molecular can be definitely help. They can help over any diagnostic dilemma. Before going to the context of lymphoma, these are some universal principles which apply to everything in history. Number one is fixation. You have to have a proper fixative tissue to go about diagnosing you. This is the number one thing. Before, and it's not true only for lymphomas, it's true for everything you deal in history. And especially in the context of lymphomas. Why is it important? Lymphomas are hypercellular neoplasms, especially the hybrid lymphomas. So you have many cells in a lymph node, which lymph node itself is not able to handle. Now, when you get a good section, say a 3 centimeter or 4 centimeter lymph node, and without fixation, you directly process it for grossing, that is not the ideal scenario. You get a 3 to 4 centimeter big node, and the suspicion is lymphoma, you fix it for at least 1 day overnight. At least overnight, you fix it, you strip it, and you fix it. And next day, you submit for processing. So that's how we deal with lymphomas, which are lymph nodes which are bigger and which are suspected to be lymphomas. Then, and that is 10% neutral buffer formalin is the most important thing. You have to have a formalin which is 10% neutral buffer formalin to have, so that you can be an expert in your histologic observations. Because I tell you, if you are fixing it proper, if you're fixing a 10% neutral buffer formalin, I can tell you with, and if you develop your histologic acumen, you can give a proper working diagnosis on histology itself and maybe not take so much help of ISC. So outermost rim of lymph node usually, and the central zone also are not the best places to see. The intermediate zone are usually the best places to see for lymphomas. Now when we go about grossing, we look at the size, consistency, preservation of hilus is there or not, presence or absence of nodularity is there or not, presence of necrosis is there or not, because if your necrosis probably indicates it's a high-grade lymphoma. Adherence, whether the node is adhering to the surrounding tissues, and your section perpendicular to the long axis in a clean sweep. So this is how we know a gross lymph node looks like. These are nodules which you can see here, right? So this indicates probably there is something which is occurring in that part of the node. Now before again I go to the lymphomas, you must understand the normal histology of a lymph node. So this is most important. If you do not understand this, there's no business of doing lymphomas. So you must understand that this is a normal node. you have the cortex, you have the medulla, you have the cortical nodules that we call primary follicle or secondary follicle. So primary follicle you see in nodes which are not yet antigen stimulated. Once the primary follicle gets stimulated, it becomes a secondary follicle, which we know by the paternity of germinal centers. So you say for logic, where can you find primary follicles in nodes? You will find those in nodes which are usually not susceptible to antigenic stimulation, say intra-abdominal nodes, not palpable nodes. Intra-abdominal nodes are not usually antigenically stimulated because they are not, they don't encounter foreign antigens that much. So you find primary follicles in intra-abdominal nodes, where in palpable nodes in the body or in entries of the of our body, you will find more of secondary follicles. You don't see primary follicles. You see germinal centers. So you see germinal centers there, and then you find that there is usually centered in the cortex. Medulla is usually follicle-less, and you see more of cells which are not concentrated there. There is an interfollicular zone which is rich in T cells. The germinal centers are rich in B cells. So you have the T cell areas, you have the B cell areas, and these areas usually you find plasma cells, macrophages, all that. So you can see here, secondary follicle means germinal center plus mantle zone. So this is germinal center here, this is a secondary follicle. So you, how to identify secondary follicle? You have the germinal center and you have the mantle zone. Mantle basically means shell. The literal meaning of mantle is shell. So it basically shells or protects the germinal center. So if a mantle zone, you have a germinal center. And sometimes in abdominal nodes, you can still make out that there is another layer here, which is the marginal zone. Okay, because the marginal zone, why is there? In abdominal nodes, because there is a gut. So there those nodes encounter antigens from the gut. And in that, they need to develop, they have a special capacity to develop immunoglobulin, so that they can, fight against those foreign antigens. So in the marginal zone, you have cells which are more capable of producing antibodies, immunoglobulins. So those are your marginal zone cells. So you normally don't encounter when you get the superficial node. So you have the germinal center, you have the mantle zone, and you have the marginal zone. So that constitutes our secondary follicle. Now, so secondary follicle, as I told you, you have the germinal center and you have the mantle zone. And in this germinal center, you have the dark zone and you have the light zone. As Patni sir already alluded to, he made things easier for me because I will be going into the basics, very basic. So I can just go on from here. So it's the centrocytes, you find the centroblast and you find the centrocytes, and most importantly, you have the tingible polymer. So basically this germinal center, how we look at it. Now you have to get this concept right, okay? So this germinal center is the home of B cells, right? So this germinal center is the home of B cells, number one. Number two, it is the dynamic structure. By what do I mean by dynamic? That there is mitosis and reproduction going on in this area. So cells are transforming, cells are dying, cells are being born. Okay, so there is a dynamic structure going on, so reproduction is going on, and because of the reproduction going on, the debris which is produced has to be taken away, right? Like we in our homes, when we have waste, we put it outside so that the sweepers, they take it away. So they are the scavengers. So in the scavengers in a node are which one? They are the tingible body macrophages. So in a normal germinal center, you should have a light zone and a dark zone. You should have centroblast and centrocytes. So you have a polymorphous population. You have the tingible body macrophages. And apart from this, now when I say this is a home, like I say this is a room, right? This is a room. So these cells are the population which is sitting, like we all are right now. So we are all the polymorphous, right? We are sitting in a room. So consider this is a B cell. Now there has to be some pillar, right? Without the pillars, this whole room will collapse. So what are the pillars? For the pillars, you have the dendritic cells. So not shown here, but you have the dendritic cells which form the pillar of the node. So, and along with the B cells, you have some T cells also, which accompany the B cells. So the follicular helper T cells, which are inside the node. So what do we have inside the node? You have a germinal center, and in the germinal center, you have B cells, which comprise of small lymphocytes, centrocytes, centroblasts. These are your B cells and immunoblasts. Then you have some T cells, which are known as follicular helper T cells. You have the plasmacytoid dendritic cells, and you have tingible body macrophages. So these are your constituents of a normal germinal center. Okay, non-neoplastic. Now, so anything which goes on here can affect any neoplastic process can happen here. So basically, I'm saying, say if you have a B cell neoplasm, one of the clone of these will proliferate and overrun everything. So when they overrun, first thing they do is destroy their home, and then they go outside. So यहाँ पे भर जाते हैं cells, मान लो कोई clone बढ़ गया, यहाँ पे भर जाएंगे, so ये कुछ नहीं दिखेगा यहाँ पे, right? And then they overrun everything. बाहर जो security था ना metal, वो भी overrun कर दिया, उसको भी खत्म कर दिया, और फिर बाहर ये फैल जाएंगे. So B cell population वैसा ही शुरू होता है. So if हम वैसा आइडिया करें, तो हम ये बोल सकते हैं कि अगर B cell lymphoma देख रहे हो, and usually which is proliferated, not low grade, you do not expect to find germinal centers in a B cell lymphoma. अगर वो proper high grade B cell lymphoma है, तो तुमको germinal centers नहीं मिलने से. So that is a soft clue which you can use for a diagnosis of B cell lymphoma. I think we'll need more water. Okay. So this is the medulla which I told you, which is mainly populated by plasma cells and lymphocytes, and medulla is not always evident in tissue sections and the tissue. Now, before again I go to the lymphoma proper, a word about ISC. Immunochemistry, you have to understand first what is normal. Only when you understand what is normal, I mean, how do the immunochemistry markers, go about in a normal mode, then only you can understand what is abnormal. Now you also need to know which are your cells of interest. Now in a Hodgkin lymphoma, probably you know by second year or third year, the Hodgkin lymphoma is a polymorphous population plus some large cells. So you need to know which are your cells of interest. If you apply immunochemistry and then try to see the IC mainly in the polymorphous population and not on your large cells, because your large cells should be your cells of interest, then you may go awry. Same T cell lymphomas, if you do not know that your cells of interest are T cells and not a B cells, then again that IS3 can cause havoc. So you should know what your cells of interest, then you should know what is it coming positive, is it coming in the proper setting. Let's say cyclin D1. Cyclin D1 is a nuclear marker. TDP is a nuclear marker. So you have to interpret in the appropriate context. If TDP is showing you cytoplasmic flush, it is not to be taken positive. It is negative because TDP should come with nuclear positivity. So it's either positive or negative that you should know. Background cells, again you should know, are the background cells are they of value to you in the diagnosis? Say in classic Hodgkin lymphoma, you should have a polymorphous population of neutrophils, eosinophils, plasma cells, histiocytes. Anal patient, you should have more of lymphocytes. T cell histiocyte, large B cell lymphoma, you should find a polymorphous but devoid of eosinophils. Peripheral T cell lymphoma, again you should have a polymorphous population or a monomorphic population. So that thing you need to know. Controls. Now before also looking at when you look at the ISCs, you should know what is the normal control for that marker. Now if I ask you what is the normal, so in Hodgkin lymphoma you apply CD30 and CD15, right? So what is the normal marker for CD15 if I ask you? So you should know what is the normal marker for CD15. Now CD15, the normal marker is myeloid cell. So your staining should show that there is some CD15 in the neutrophils, which will be there in a Hodgkin lymphoma. So if there is absolutely no CD15 in your node, and you know on histology there are some neutrophils, but the neutrophils are not taking up CD15, then probably your CD15 and is negative in the large cells, so probably your CD15 is not working, right? And it's not negative, it's just non-contributory. Maybe you need to repeat the CD15. So you should know what are your controls of the markers. Then there can be loss of marker or aberrant expression. Like this is more important when you deal with T cell lymphomas. Because T cell lymphomas are one of the hardest to diagnose, and they depend whether there is loss of marker or there is aberrant expression. Also that can be true in some low-grade lymphomas also. And remember, this is true for most of the things in oncopathology, not specifically lymphomas. No one marker is loyal to any tube. And small because of this, if you have a smaller panel of ISCs, say you're doing only CD20 and CD3, well, they can lead to you trouble. So you may not know what are you dealing at if you do not have an extended panel of ISCs. So this is the immunophenotype of a normal node. So how do they look like? I told you the germinal centers and the primary follicles are home of B cells. And most common marker for B cells which you use in ISC is CD20. So CD20 is highlighting your B cell follicles, right? Which can be primary or can be secondary. CD3 is in the interfollicular, so it is staining the T cells. CD10 is a marker for CD10 and BCL6 are markers for germinal centers. So if I ask you what are the markers of germinal center which we commonly use in ISC, CD10 and BCL6. So CD10 is highlighting the germinal center. Now I told you these germinal centers are dynamically active, right? Reproduction is going on. So that means they are proliferating. So their Ki67, which is the proliferation index, will be high in the germinal centers and will be less outside, right? Now, what is BCL2? BCL2 is an anti-apoptotic marker. It is just the opposite of Ki6 cells. It is an anti-apoptotic marker. So BCL2 will stay in those cells which are relatively stable, which are not dynamic, right? So the node, the germinal center, which is dynamic, so it should not take BCL2. So BCL2 will be negative in a normal germinal cell. Still you see some cells there, here and there, right? These are the follicular helper T cells. The follicular helper T cells will be BCL2 positive. Outside the mantle zone is a stable zone, so it will be BCL2 positive. Some of the T cells outside will be BCL2 positive. So that's why you have to know where does BCL2 come to interpret, to be able to interpret the correct use of BCL2 in the clinical context. Now the CD21, CD23 and CD35, these are three antibodies which we use for dendritic cells. So I told you dendritic cells are there inside the node. So if you get a CD21, it will highlight the follicular dendritic cell mesh. And in some lymphomas, it's very, very important, especially to differentiate DLBCLs from relatively diffuse pattern of follicular lymphoma, whether this follicular dendritic cell mesh is present or not. Okay, so CD21 and CD23 and CD35 are important markers for follicular dendritic cell mesh. Now I go more specifically to small cell lymphoma. I will try to cover as much as possible, but I obviously can't guarantee you that I can cover everything. So I will try to do just. So I told you the clinical features is very, very important when you deal lymphoma. Specifically, when you look at small cell lymphoma, small cell non-Hodgkin's lymphoma, these are some points to be kept in your mind even before you start seeing that slide. Number one, all small cell lymphomas primarily occur in middle age to old age. You do not diagnose a small lymphocytic lymphoma in a bacha. You do not diagnose a small lymphocytic lymphoma in a 15-year-old or 20-year-old. No. You do not diagnose a mantle cell lymphoma in a 10-year-old. No. Whatever, even if a second D1 is positive, your diagnosis is wrong. But it's a DLBCL. So you do not diagnose some things in that age group. Mantle cell lymphoma usually has a male preponderance, but they doesn't much depend. Generally, they present with generalized lymphomas. Okay, usually single group they can present, but usually they present with generalized lymphomas. Bone marrow involvement is more common in small cell lymphomas than in high grade lymphomas, and these can transform over time to large cell lymphomas, which is particularly true of SLL, small lymphocytic lymphoma, follicular lymphoma, mantle cell lymphoma, and lymphoplasma cell lymphoma. There is a caveat to this, the age thing, that there are two entities, periodic type follicular lymphoma and periodic nodal margin lymphoma, which can occur in adolescents and young adults. So you can get these two entities, but you do not get mantle cell lymphoma or SLL in a young child. Now again, site considerations should be taken into account. Whether it's nodal, whether it's extranodal. Why is this important? When you get nodal, so important things is it can be SLL, MZL, MCL, LPL, follicular, right? When it's extranodal, look at what the site is. If it's stomach, breast, lung, lacrimal gland, dura, salivary gland, where there is mucosa-associated lymphoid tissue. So the primary diagnosis should be marginal lymphoma, or other words, marginal zone lymphoma. If you're getting in the GI tract, apart from marginal lymphoma, there can be follicular, MCL, and mantle cell lymphoma. If you're getting skin, then you are getting a cutaneous, either it is an MZL cutaneous or it's a primary follicular central cell lymphoma or systemic follicular lymphoma. If you're getting, I told you the small lymphomas have a propensity to involve the bone marrow. So you can, all the lymphomas can involve the bone marrow. And in spleen, there are certain entities specific to the spleen, like MZL and hairy cell leukemia, hairy cell leukemia variant, which are specific to the spleen. So this is the site conservation. Now remember from one point you can remember for life is, number one, if you see closely all these entities here, which are made here, there is no SLL in the extranodal group. So that means SLL is not the diagnosis you make at extranodal sites. It's very, 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 very rare if you're making a diagnosis of SLL at extranodal sites. Right? So it has to have some component of lymphoid tissue there. Say you you're making a diagnosis of SLL at, say, in the elbow. Right? You have to now decide that lymphoma probably has arisen from an epitrochlear node. That is only surmise. If it's not an epitrochlear node, you cannot have an SLL at extranodal site, just like that. Right? It's very rare, very rare. So you should be very, careful about making a diagnosis, especially in this setting that I told you. Now coming to a proper approach to lymphoma, the first thing you see is the lymph nodal architecture. The first thing you see as I'll be dealing, when I'll be taking the live slide demo, I'll be dealing with this thing more and more. Then the first thing you say is the effacement, whether the lymph node architecture which I showed you, the cortex, the medulla, the primary, secondary follicle, the cellular orientation, is that maintained or not? If it's not maintained, the term we use is effacement, right? So it can be either partially effaced or it may be diffusely effaced. If it is effaced, that is the first clue that possibly looking at a neoplastic disease and not at the reactive lymph adenopathy. Number one. Number two, what constitutes effaced architecture? There are two terms which you only use, whether it's diffuse or it is partial. When you say diffuse, you know that, okay, there's nothing there. It's just sheets and sheets of your epithelial lymphoid cells. Sometimes lymphomas can also have a partial or nodular involvement or can have intrasinusoidal. So that can be difficult to appreciate on a core biopsy. So that's why inserted is more always better and appreciable from the clinician side if you get an excision biopsy. You can do only features of an excision biopsy. Now some lymphomas, particularly T-cell lymphomas, which are more treacherous to diagnose, do not show overt architectural effacement in initial stage. They may not show your effacement also. So that point also has to be taken into account. Now next we talk of the cell size, right, which is very, very important. So how you determine the cell size when you look at a biopsy? So that you determine taking into consideration the size of the histiocytes for endothelial cells, which will be always there in a node. So you compare the size with these cells. If it is smaller, as you can see from this diagram, if it is smaller, it is a small cell lymphoma. It is same size, medium cell lymphoma. It is large, it is a large cell lymphoma. That is how you compare the size of the lymphoid cells. Now coming to the pattern. So when we put a slide under the scanner, and there has to be a scanner, you cannot just put it on 10x. You have to have a 4x or a 2x preferably if you are going to diagnose lymphomas. So start seeing at 4x, and then you see whether, and what do? Once you start put the slide, you decrease the illumination. That's the first thing you do. You do not see a lymphoma slide in the same illumination like you see other slides. No, that is not done. You have to decrease the illumination. That's the first thing. So I'm telling you, I'm not talking of lymphoma per se. These are the basic things which you need to understand as a budding pathologist. You put the slide, take it to the scanner view, and decrease the illumination. So if you say a previous person sitting at the microscope has put the like this same thing where the light is on, you do not put the slide here in a lymphoma and just start seeing. Say no, that is not done. First thing is here, you decrease the illumination as much as possible, so that it is faintly visible. Why? Because sometimes follicular lymphomas will have nodules which will not be visible just under this kind of illumination. So you have to really decrease the illumination to identify whether they are a nodular pattern or not, right? So that is the first thing you do, and then you go about seeing the patterns, whether it is diffuse, whether it is follicular, whether it is interfollicular expansion, or whether it is interfollicular expansion with mixed small and large cells. So if you have diffuse pattern, these entities will be the primary differential diagnosis. SLL, MCL, MZL, LPL. I'm not telling the full names because I think you already know. It's a follicular pattern, the primary diagnosis is follicular lymphoma. Right? But remember, other than follicular lymphoma, these two also can have a follicular or a nodular pattern. Okay? Then you have the inter-expansion with diffuse areas. SLL, MCL, MZL. And you can have mixed small and large cells. You can have, these are basically small cells, but sometimes you can have large cells. Like SLL will increase proliferation. Follicular lymphoma grade 3A. LPL, MZL will increase large cells. These things are rare, but can happen, and you can encounter these in your daily practice also. Now, I'll be more concerned with B-cell lymphomas. Your T-cell lymphomas and Hodgkin's is another big chunk. So I'll be more concerned with what we commonly encounter, and what we commonly encounter are the B-cell lymphomas. So how do you approach, and what are the list of, when I say small cell, when I say medium to large, what are the entities to keep in mind? So when I say small size lymphoid cells, I told you about a pattern, whether it's diffuse, whether it's follicular, whether it's vague nodular or mixed architecture. And you have these entities in mind. But look at point after 6. So you usually low-grade lymphomas with indolent clinical course. These all lymphomas usually have indolent clinical course. Exception can be mantle cell lymphoma follicular grade 3, which can have an aggressive behavior like medium cell or like large cell lymphoma. Usually affect adults. Exception I told you is pediatric follicular and pediatric marginal zone lymphoma. Otherwise, these usually affect adults that to in a middle or elderly age group. Medium to large cells usually has a diffuse architecture. It's very rare to find medium to large cells to find a nodular architecture. Yeah? Usually they present here in sheets. So you have Burkitt, B lymphoblastic lymphoma, T lymphoblastic lymphoma as well, DLBCL types, all these are DLBCL types, and generally high grade with aggressive clinical course. Exception can be lymphomatosis, which it has grading, and depending on the grade, it can be low grade behavior also. And this usually affects children as well as adults. So your high grade can affect children as well as adults. Some more common in children, like these two, and some more common in adults. But these are more likely to occur in adults, not in children. These can occur in both the age groups. But do not forget the T cell lymphomas. So because if you are just concentrating on B cell, you may have same patterns and you may have a T cell lymphoma lurking in there, not a B cell lymphoma. So never forget, if your immunos and your proper histology is not coming as per B cell lymphomas, do not forget that you may be looking at T cell lymphomas also. And they can have any of the patterns, anything which I am going on telling can have a T cell lymphoma, can occur in T cell lymphoma also. Now, hallmark of lymphoma is the mononuclear neoplastic lymphocytes that we all know. Now, I think Patni sir already alluded to this. So you must know how B cell maturation, this is a B cell autosony, and along with that you must know what markers are there. So when I say B cell, these are the pan B cell markers. 19 is usually used in flow cytometry, we do not use in ISC. In ISC we use CD20, CD17 and PET. So these are our pan B cell markers. Then you go to the Jamanet center, and inside the Jamanet center there again set of markers. These are your Jamanet center markers. Commonly we use CD10, BCL6. So CD10, BCL6 are your Jamanet center marker. There are other few more markers which you can use in Jamanet centers, but commonly use CD10. Others are HGAL, GCL, LMO2, these other markers, but commonly we use CD10 and BCL6. So these indicate that if you are getting a CD10 positive lymphoma, a BCL6 positive lymphoma, then probably that lymphoma is arising from a Jamanet center cell. Then you have, when it differentiates and becomes a plasma cell or a memory cell, in plasma cell it loses CD20 and it acquires MUM1 and CD38 and CD138. Now CD138 is not specific for a plasma cell. CD138 can come in any cell which is a plasmacytoid look. A plasmacytoid appearance, if you are getting even epithelial cell has a plasmacytoid, we find CD138 positive. If an osteoblast in bone marrow or bone which has a plasmacytoid look, they can come 138 positive. So the more defining marker for plasma cell is MUM1 and not CD138. So MUM1 should be positive when you are dealing, if you are calling something a plasma cell, your MUM1 should be positive. Apart from this, there are OCT2 and BOB1 which are transcription factors expressed by B cells. And remember CD30 is a lymphocyte activation marker. So CD30 is a marker which comes positive in Hodgkin cells, right? There you are right. But CD30 is not a Hodgkin cell marker. CD30 is a lymphocyte activation marker. So CD30 can come positive apart from Hodgkin cells. It can come positive in activated lymphocytes also. So that another point you need to remember before, because otherwise if you don't remember, you can confuse with classic Hodgkin lymphoma. So what is the basic ISC panel we use when we deal with B cell lymphoma? So any pan-B marker, we use CD3 and we use Ki67. Ki67 is more preferably used in low-grade lymphomas than in high-grade lymphomas. So what are common B cell markers I told you? CD20, CD17, backside, these are used in B cell lymphoma. There are some caveats with regard to use of CD20 and CD17 and A. Relapse or partially treated NHL. You know NHL is treated by R-CHOP. What is R? R is rituximab. So it's an anti-CD20 antibody. So if you get a lymphoma which has already been treated with rituximab, in spite of it being a B cell lymphoma, the CD20 will come or can come negative. So in such situations, you need to use one more B cell marker, which can be 17 and A or backside, to categorize it as a B cell lymphoma. But 79 is remaining. B lymphoblastic lymphoma, because CD20 is actually a marker for mature B cells. So in the primitive B cells, your CD20 can be negative. So if you're getting a B lymphoblastic lymphoma, your CD20 can be negative. So in those cases, you use CD79A. Then B NHLs with plasmablastic or plasmacytic morphology like plasmablastic lymphoma are usually CD20 negative, but they can still retain CD79A. So based on the size of the lymphoid cells and architecture, you need to use your panel for B NHL. So what is the common panels we use? Of small size lymphomas, in this distribution, we usually use, apart from CD20 and CD3, use CD5, CD23, 10, BCL6, BCL2, sometimes, not everyone, not every time, and 138 or 38 and now one if you're dealing with, you think you're dealing with LPL. The important thing to remember here is that I've shown you this table, and we, you know, in your PG days, even when you're preparing for PG entrance, we used to read this table. Right? So many of you probably know this table. But what have I circled? And why have I circled this? Because these markers can be variable. So it's not necessary always that your SLL will always be CD5 positive. There are many cases of CD5 negative SLL. So that doesn't render your diagnosis wrong. But the ones I have circled is more important. So if you're getting a follicular lymphoma, it should be 10 and BCL6 positive in most cases. Right? It's very rare to get a CD10. There are, but very rare to get CD10 BCL6 negative follicular lymphoma. Mantle cell lymphomas are usually cyclin D1 positive. So if your lymphoma stays cyclin D1 positive and 20 positive, irrespective of the other markers, it is a mantle cell. Done. Then you do not go about whether it's 5, what is the status of 5, what is the status of 23. No, don't worry. If a cyclin D1 is positive, it is a mantle cell lymphoma. If a mantle cyclin D1 is negative, but SOX11 is positive, still it's a mantle cell lymphoma. Right? So you do not worry that time whether what is the status of your CD5 and CD23. No. So that's why I've circled this. These two are most important when you're dealing with the low grade. Now a little about entities. SLL, CSL. We call it CLL when it mainly is a diagnosis made in peripheral blood or bone marrow. We call it SLL when you make a diagnosis in solid tissues, right? Lymph nodes. So this criteria is already there in your textbooks. I'm not going in the details here. What is important is the morphology of SLL. So SLL is usually present in a diffuse pattern. Sometimes it can give a pale nodular pattern as well. Markers which come positive is CD20, CD5, CD23, 10 negative, cyclin D1 negative, BCL6 negative. I told you 10 BCL6 is a marker for. Can you be more responsive? CD10 and BCL6 are markers for germinal center. So 10 and BCL6 should be negative for diagnosis of SLL. So if 10 and BCL6 are positive, the diagnosis probably is follicular lymphoma. They already know. So their diagnosis then is follicular lymphoma, right? So, but sometimes in SLL there can be variations. Every lymphoma there can be variations, which we should always be wary of, because we are not aware of, then we can make an error in our diagnosis. So it can have more proliferation centers. It can have pro-lymphocytes in between, and it can have para-immunoblastic variant when you get more cells which are open in chromatin, slightly larger in size, but those are still a diagnosis of SLL. Sometimes SLL can, which we know is Richter syndrome. What is the Richter syndrome? Basically, it's a large cell transformation. SLL becoming DLBC. That is Richter syndrome, and it's not specific for SLL. Any low-grade lymphoma can show you large cell transformation. Now coming to follicular lymphoma. So what is the definition of follicular? This is a WHO definition of follicular lymphoma, and you should be very careful the words that are used in the definition of follicular lymphoma. Read it. So the neoplasm of germinal center B cells with varying proportions of centrocytes and centroblast or large transformed cells, and at least a partially follicular growth pattern. This is very, very important, because sometimes you get a follicular pattern and in other areas you get a diffuse pattern. That is not a DLBCL. That is still can be a follicular lymphoma depending on your other markers what are coming and the context of the patient. So it can still be, so you need at least a partial follicular growth pattern. Now remember, if it is diffuse, then what? If it is diffuse, in rare cases with an entirely diffuse growth pattern, the neoplastic cells should still show a germinal center B cell morphology and immunophenotype, and that diffuse growth pattern should be composed mostly of centrocytes. If that diffuse growth pattern is composed mostly of centroblast, then it is DLBC. Even if it is DC phenotype, because we know there is CD10 BCL is positive DLBCs. Right? So that is very important to understand. So this is a typical pattern we see in follicular lymphomas. You have a phase architecture, and it is nodules and nodules, back-to-back arrangement of nodules. And in the nodules we can see there can be a slight mantle but not a developed mantle zone. The polarization is lost. You do not find tangible body macrophages here. There is one important clue that probably you're looking at a follicular lymphoma and not at the reactive lymphoid hyperplasia. This is the pattern as I showed, and inside you find a polymorphous population of centrocytes and centroblast. So there are two populations which you find, centrocytes and centroblast. You do not see macrophages, you do not see dendritic cells that much, you do not see small lymphocytes there. So all these things are done. And you find CD20 positive, CD3 can be positive in the follicular helper T cells and outside. CD10 is positive, BCL6 is positive, BCL6 is positive along with CD10, and BCL2 is also positive. Routinely, I do not use BCL2 in the diagnosis, but you can use as a beginner. So BCL2 will be positive in the nodules, because this is now a stable zone. Germinal center was a dynamically active zone, where BCL2 is supposed to be negative. In follicular lymphoma, the cells do not die. So when I say low-grade lymphoma, the concept is in low-grade lymphoma, the cells become stable. They do not reproduce. So if they do not reproduce, your Ki67 will be low, your BCL2 will be positive. So that is the concept of BCL2 and Ki67. So in that, if I extrapolate this BCL2 thing, that means BCL2 is not a marker or a specific marker for follicular lymphoma. No. So you have to get out of what the book says. The book, always, every book you see, you say that BCL2 is a marker for follicular lymphoma. No, wrong, completely wrong. BCL2 is a marker for a low-grade lymphoma. It's a marker for cells which are stable and which are not reproducing. That's BCL2, right? So you don't diagnose follicular lymphoma on the basis of BCL2. No, BCL2 will come positive in follicular lymphoma, but that doesn't make a diagnosis of follicular lymphoma. For follicular lymphoma, you have to have a prototypical setting, you have to do histology, you have to have CD10 and BCL6 positivity, which is much more important than your BCL2. I have 5 minutes left. I have a lot of things, but this is in your textbooks. I am not going to the details. And how you diagnose follicular lymphoma? Just a algorithmic approach how to diagnose. Because follicular lymphoma is one thing which I have seen across in my experience. If you go to core biopsy and you are not well adapted to how you can make a diagnosis core biopsy, you are bound to go wrong. So follicular lymphoma is not that uncommon. It's because we underdiagnose follicular lymphoma. That's why we tend to think, okay, it's uncommon. It's not that uncommon. So how do you go about it? You get a nodule and you see whether follicles are present or not. Number one. Number two, if yes, whether it's showing a mixture of centrocytes and centroblasts. If it's showing a mixture, it is a classic effect. No bones about it. Now, if it's not showing a follicular pattern, whether it's showing a diffuse pattern, then you can still be follicular, as I told you, with a diffuse follicular pattern, which should be composed primarily of centrocytes. Now, if it's showing a follicular pattern, in all these it's showing a follicular pattern, but it is not a mixture of centrocytes and centroblasts. So two scenarios. Either it is composed of primarily large cells, which are centroblast, with absence of totally centrocytes. So this is now follicular large B-cell lymphoma. So you have nodules, and in that nodules you have large cells, right, which look like centroblast. So that is follicular large B-cell lymphoma. Earlier it was called follicular lymphoma grade 3B. Now it has been renamed as follicular large B-cell lymphoma. So it's not DLBCL. And why is it important? Why I'm harping on this? It's not DLBCL, it's not, because DLBCL will be treated with R-CHOP. Follicular lymphoma is not treated with R-CHOP. So if you treat a follicular lymphoma with R-CHOP, there will be two things. Number one, you're giving a more aggressive therapy to a person who is not suffering from the disease. Number two, that follicular lymphoma is not going to respond in the appropriate way as does a DLBCL. So that's why you need to differentiate whether it's a DLBCL or a follicular lymphoma. And if this follicular lymphoma has predominantly medium-sized cells with some unusual pattern, there are large centrocytes, and it's not centroblast, then it can come in unusual cytosis, which is a rare entity, but it can so happen. And in some situations when there is doubt, always resort to cytogenetics, because you can see BCL2 rearrangement in follicular lymphomas. So you can diffuse growth pattern. How I told you, many pathologists and budding pathologists may diagnose this as a DLBCL. No, this is not a DLBCL. You can see still this septa. Fine, these are not septa, these are actually small lymphocytes which are bounding, you're making a bounded. So you're getting sheets, you get always sheets, and you do not see this dark staining pattern. Then it's a diffuse sheets. This is all composed of centrocytes. So you have follicular lymphoma, and now the grading is almost redundant. You can do away with the grading, you may not do grading, but you can also do a grading. There is difference of opinion between ICC and WHO classifications, as was told by Neeraj sir. So there is a difference between FL, I'm not going to slide, mantle cell lymphoma. Now, mantle cell lymphoma can usually have a sheeting pattern, it can have nodule also, and it usually expresses most importantly is 5, SOX level 66. So cyclin D1 is the most important marker for mantle cell lymphoma. So there is a cyclin D1 positive mantle cell, there is cyclin D1 negative. Cyclin D1 positive will be, centrocyte-like cells, and in cyclin D1 you get SOX11 positivity. So mantle cell usually comes with these pattern. It can have nodular pattern. It can have mantle cell. So the mantle cells can be hyperplastic in this pattern. It can have a proper nodular pattern. It can have a diffuse pattern. So it can come with all these patterns. The important thing is to see how the cells are. How you make out what the cells are, whether it is mantle cell cells or it's SLL cells. Small lymphocytic lymphoma, the cells, the nuclei will be round to oval, usually round to oval. So you go to 40X and you see how is the cytomorphology of the cells. If it's round to oval cells present in sheath, probably it's SLL. If you have a sheeting pattern, but cells are not round to oval, they are somewhat angulate, indented, and there's no follicle, there are no nodules, then probably you are dealing with mantle cell. But remember, this diagnosis again may not be sacrosanct. You need to do ISTs. If cyclin D1 positive comes positive in the small round cell, because mantle cell can also have a small cell morphology. If cyclin D1 comes positive, it is a mantle cell lymphoma, irrespective of how your morphology is. So still you can give a differential, but maybe resort to ISTs in such cases. So this is again the variations of mantle cell lymphoma, where they can be blastoid, pleomorphic, small cell, I told you. So this small cell can mimic your SLL. This blastoid can mimic lymphoblastic lymphoma. So you see an 11-year-old. Say you have an 11-year-old using a blastoid morphology, then probably it's lymphoblastic lymphoma. But cyclin D1 comes positive, then what do you do? Right? It is not mantle, still it's not mantle. You need to do other markers to see whether it's positive. So you have a 50-year-old when cyclin D1 is positive and it is a blastoid appearance, but TDT is negative, CD34 is negative, then it's a mantle cell lymphoma, blastoid variant. Pleomorphic variants you can confuse with DLBCLs. So these are the variants which I told you of mantle cell. Coming to marginal zone lymphoma, the important thing is that marginal zone lymphoma, it can have three parts. It can have an extranodal part, usually occurs in mucosa and lymphoid tissues. It can have a nodal part and it can have a splenic zone. Important of marginal zone is to you identify the cell morphology. It can be in any pattern. Usually in diffuse, it can have nodular pattern also. But look at the cell morphology. Usually they are small to medium size. They have a pale cytoplasm and they have a monocytoid looking nucleus. So that is how you identify. Probably we're looking at the marginal zone lymphoma only on an HLA section. And you have sometimes one third cells can be plasma cells. So this one lymphoma which usually comes with plasma cells. So this is one and usually occurs in mucosa associated lymphoid tissues. And what two markers? It will show you CD20 for markers and it will be negative for all other markers. So it will be negative for 10, BCL6, cyclin D1, 5, 23, all markers will be negative. It will be positive only for your 10 reason. So this is a marginal zone lymphoma, and then LPL is more a diagnosis which you make in peripheral blood or bone marrow, while the strong macroglobulinous counterpart, Herisovic again is diagnosis which you mainly make on bone marrow, not going into details, a word of caution. So in a poorly fixed or suboptimally processed tissue, Burkitt lymphomas or lymphoblastic lymphomas may also look deceptively small. That's why fixation is so important. To be seriously, and these entities will be seriously considered Burkitt or lymphoblastic, because I told you, mantle doesn't occur in a small child. So if it occurs in a small child, probably looking at these and not a small cell lymphoma. Diagnosis of follicular should be made with utmost caution in children, except if it is pediatric follicular lymphoma. There can be paratrabecular lymphoid infiltrate, which can support diagnosis of follicular. And remember, it's low-grade follicular, which is more likely to involve bone marrow than a high-grade follicular. Medium size, just a word about medium size, and I just take maybe 5 minutes just to cover a medium size and large cell populations. So when you get a medium size, now the cell size is similar to the size of a histiocyte or endothelial cell. You have these entities. Why I have marked those three entities in red? Because they are the most common. So when you get a medium sized population, you either think of lymphoblastic lymphoma, Burkitt lymphoma, and these are more pediatric lymphomas or young adults. DLBCL high-grade lymphomas can also occur in children, but they are most common in adults. They can usually have large cells, but they can also have mid-sizes. PTCL, NOS, and NK cell lymphoma can have large mantle cell, middle-sized cells as well as large cells. Mantle cell lymphoma, the blastoid variant, can have medium-sized cells. Myelosarcoma is some one entity which you may not be able to diagnose at the first go. You need more markers. Nodal marginal zone, follicular grade 3B, and systemic mastocytosis are rare conditions which can be present with medium-sized population. So when you get a medium-sized population, what is the first thing you do? After you've identified, okay, it is diffuse, it's not individually nodules, it is diffuse, you look at the cytology and you see whether it is monomorphism or pleomorphism. That's the first thing you do. So if it's monomorphic, then probably it's Burkitt or lymphoblastic lymphoma. If it's pleomorphic, then probably it's DLBCL or your PTCL NOS or other types. So you get monomorphic medium-sized population, probably looking at these two entities most common in the appropriate clinical setting. Burkitt lymphoma and lymphoblastic lymphoma, you know, I'm not going into details here, but one thing I can tell you that you can still make a diagnosis on HLE on the clinical context and with the appropriate histologic findings. I'm not going into details here in context of time, but one thing you need to know, these need to be differentiated. These need to be differentiated. Why? Because Burkitt lymphoma mandates more aggressive treatment. Burkitt lymphoma is one lymphoma which, if not diagnosed or underdiagnosed or misdiagnosed, the patient will suffer like anything. But if properly diagnosed and chemotherapy is started at the right time, it is one lymphoma which responds dramatically. It's just like APML in your counterpart of liquid hemap. APML, if you diagnose correctly, responds dramatically. Burkitt lymphoma, you correctly diagnose, it responds dramatically. The patient will always be sick. The LDH will always be high. But if you start chemotherapy at the appropriate time, it will respond dramatically. How you differentiate between these two, apart from this, is one marker which you can use is TDT. TDT is a very good marker. TDT is a marker for blastic morphology, blastic nature. If TDT is positive, it is lymphoblastic lymphoma. If TDT is negative, it usually is Burkitt lymphoma. And remember, Burkitt lymphoma is origin of cell is dominant center, so it will be cell CD10, BCL6 positive. And it will be positive for CD20. TDTs are usually negative for CD20. Now, just a bit about T-cell lymphoma. So, T-cell lymphomas are one of the most difficult to diagnose. But can we predict from the histology whether we're looking at T-cell lymphoma? So, these are important, some soft clues which you can use to, keep in your mind that probably you might be dealing with a T-cell lymphoma. Though there is no single pathognomic feature. Number one, predominant involvement of the paracortical regions. Number two, prominent high endothelial value. So in the biopsy, along with the lymphoma cells, you see prominent vasculation. Number three, spectrum of cells, size and shape. They can be small, mid-sized, large cells. Marked irregular nuclear contours. Many cells with pale to clear cytoplasm. Presence of admixed electrical histiocytes and eosinophils. And in ENKT cell lymphoma, it can be extranodal disease with prominent angiocentric growth and necrosis and destruction. So there are soft clues which can help you that probably you're dealing with a T cell lymphoma and not a B cell lymphoma. So this is a morphology, you can look at in your textbooks. One important entity which you should not miss is AIT, angioimmunoblastic T cell lymphoma, which is a type of peripheral T cell lymphoma and can be confused with classic Hodgkin lymphoma. Another entity which is not a lymphoma but a hematolymphoid neoplasm is myeloid sarcoma. So if you put you're thinking it's a hematolymphoid, but somehow your markers are not coming, 20 is negative, 17 is negative, 3 is negative, 7 is negative, then probably you are dealing on myeloid. What is the clue? Look for variation in cell size. So exactly like you identify myelocytes in the peripheral blood, same type of cell you will find here. And you will find eosinophils also. So if you're getting eosinophils and it's not ALCL, probably you're looking at a myeloid sarcoma. System is very rare, but here also you find lots of eosinophils. So this is some approach which I took out from a journal, and how to just get an idea on histology itself, whether you're looking at lymphoma or just a lymphoid proliferation. So what you do is, you will see whether it's a pattern, whether it's diffuse, whether it is small lymphocyte, mixed, small or medium. So I'm not pertaining this to large cell, this is only small, medium size. And initially you found this, you put CD20 and CD3. So suppose you have only CD20 and CD3, so you put. And now based on CD20, you know whether it's B cell predominant or T cell. So suppose you have these three scenarios. Number one, mark predominance of B cells based on your diffuse CD20 positive. Now how do you go about? So you see whether the B cells are in dense sheets and there is very less admixture of T cells. CD3 is very less. That means it's a B cell. No, this is the easiest to crack. Second, you have B cells in sheets, but you have many admixed T cells. Now what do you do? In this scenario, you see whether there is any aberrant phenotype which is expressed in the B cells. Say so a B cell is expressing CD5. The CD5 is a T cell marker, it's not a B cell marker. So if it's expressing aberrant phenotype or cyclin D1, then it's a B cell lymphoma. If it's not expressing aberrant phenotype and you have this admixture, then possibly reactive, but if your histologic features are suspicious, label at atypical lymphoid hyperplasia and advise follow-up, or you can go for molecular studies. You look at immunoglobulin gene rearrangement or T-cell receptor gene rearrangement. Okay? Now, in the second scenario, you have an equal admixture of B and T cells. See the psychology of the B and T cells. If your atypical or large cells are taking 20 positivity, that means they are selectively B cells, then see again whether these are expressing any aberrant phenotype. If they are B cells. If they are not, it will come here. Now, if their psychology is atypical or atypical T cells and absent, this aberrant phenotype is there, it will go to atypical lymphoid hyperplasia. Now, if you have marked predominance of T cells, look whether there is loss. Now, how you diagnose T cell lymphomas? Number one, the clinical context is very important. Say you get an 11-year or 12-year-old child, and you have this diffuse CD3 positivity, right? Be careful of diagnosing a peripheral T cell lymphoma, NOS, apart from ALCL, in a child. PTCL NOS are very, very rare in a child. So be very careful about the context when you go about again diagnosing lymphomas. So mark predominance of T cells, look for aberrant immunophenotype. Any T cell lymphoma happens is there is loss of one or more markers. So you know CD2, CD3, CD4, CD5, CD7, CD8. CD6 is not here. CD1 is not T cell, CD1 is something else. CD2, CD3, CD4, CD5, 6 is not there, 7 and 8. These are all T cell markers. So in T cell lymphomas, there is loss of one or more T cell entities. That's how you diagnose T cell lymphoma. So look for this aberrant phenotype. If it is present, you diagnose it as either peripheral T cell lymphoma and T cell lymphoma based on CD15 positivity, or if absent, then you give this comment. So that's how you can coolly still diagnose a lymphoma based on histology and limited IC band if you have. Just a word again about the large cells. So NHL, large cells, if you say, the number one entity is DLBC. Second is anaplastic large cell lymphoma. Classic Hodgkin lymphoma, the large cells usually are very few numbers. Sometimes classic lymphoma can show you large cell predominance, usually in syncytial period nodulosclerosis or in lymphocyte depleted classic Hodgkin. Some rare varieties which can present with large cell lymphomas is plasmablastic lymphoma, pleomorphic mantle, I told you, histiocytic and dendritic cell lymphomas like say follicular dendritic cell sarcomas can present with large cells. Other rare entities are PTCL can also have large cells, and as positive large B cell lymphomas are another entity which can come with large cell morphology. So this is a DLBC which is commonly encountered. I will be showing slides as well. So this is the most common lymphoma. In our practice, the most common lymphoma which you get is DLBC. The second most common lymphoma we get is classic Hodgkin lymphoma. So DLBC number one, classic Hodgkin number two. And you need to know this Hans algorithm when you go about diagnosing and subtyping the lymphoma. So diagnosis of DLBCL is not complete without this subtyping. For subtyping, you use this Hans algorithm. So if three markers which are taken into importance: CD10, BCL6, MOM. CD10, BCL6, MOM. So if CD10 is positive, it is straight away germinal center. Don't worry about BCL6 and MOM. Because CD10 is positive, it is straight away germinal center. Okay? Now, if CD10 is negative, then you see whether BCL6 and MOM1 is positive. If BCL6 is positive, MOM1 is negative, BCL6 marker for germinal center. So it will be germinal center. If BCL6 and MOM1 both are positive, then MOM1 takes precedence. Right? Then MOM1 takes precedence. So CD10 negative, BCL6 positive, MOM1 positive, it is the activated B cell type. If 10 negative, BCL6 negative, MOM1 positive, activated B cell type. If CD10 negative, BCL6 negative, MOM1 negative, then what? It is still an activated B cell type. So in other words, for it to be a germinal center type, at least one of the CD10 has to be positive, or in the context of MOM1 negativity, BCL6 has to be positive. If BCL6 and MOM1 both are positive, it is activated B cell type. And it is taken into account when more than 30% of cells are positive. Why is it important to subtype? Because DC pattern is on to be more favorable than an activated B cell type pattern. So these are the large cell types, this is plasmablastic morphology, this is a plasmablastic lymphoma, which can exactly look like a DLBCL. And you sometimes do FISH for categorizing whether it's a double hit lymphoma, which is now the trend. You need to do FISH for CMYC and BCL2 rearrangement in any DLBCL. And sometimes Burkitt can show you a large morphology, but they lack rearrangement and they are 11 preparations. One of the lymphomas which we need to be very careful about is anaplastic large cell lymphoma. Why? Because I consider anaplastic large cell lymphoma the melanoma of hematolymphoid nucleus. Why? Because ALCL can look like anything. It can just look like anything. It can look like a carcinoma, It can look like a melanoma, it can look like a sarcoma, it can look like a plasma cell neoplasm, it can look like anything. So you need to always keep this entirety in mind if you are dealing with something which is medium to large cells morphology. So ALCL is one thing you should not never miss, and CD30 is a very good marker, and it always diffuse positive in ALCL. There is no ALCL without CD30 positive. So CD30 has to be positive for a diagnosis of ALCL. As positive, it becomes L positive ALCL. As negative, it becomes L negative ALCL. But CD30 has to be positive. Another entity which can present with the large cell morphology is as positive large cell B-cell lymphoma. Why this is important? Because it does not respond that well to R-CHOP therapy or other therapies. And how you diagnose? The clue to diagnosis is it will have a monomorphic large cell morphology. There will not be a morphism. Number one, monomorphic plasmacytoid plasmablastic morphology. And the only one marker which comes, two markers which come positive is MUM1 and CD130. All other markers can be negative in this entity. All other markers. So you get all negative, but you get 138 positive because it is plasmacytoid appearance, and you get MUM1 positive because it arises from a terminally differentiated B cell. So you get a MUM1 positivity, it becomes a L positive large B cell lymphoma. CD30 will be negative. If CD30 is positive here, it is a ALCL. PLC is a lymphoma. And it will respond good to R-CHOP, to CHOP. If it is L positive large B cell lymphoma, it doesn't respond that well to CHOP or R-CHOP. And usually occurs in young adults. So you have this, if you make a correct diagnosis, the patient can have a long life. So this is how you go about the immunophenotype of DLBCL. It's a uniform CD20 positive, ALCL is 30 positive, Tassi-Hodgkin's 30, 15 positive, Bax5B, which is very important marker, and these are other important. And you should not miss these entities also when you are dealing with lymphoma. So just trying around up here. Just a quick word about lymphoma versus non-hematologic lymphoma. Now there is one thing you can again take a clue on HNE. I've designed this slide for HNE. So carcinomas are usually cohesive, short boundary with stroma, nuclear molding and streaming can be seen usually in neuroendocrine carcinomas, and CKs are positive. Melanoma, cohesively non-cohesive, tumor cells falling apart, and you take the markers which are positive. Lymphoma usually are non-cohesive, permeative, basophilic, thermophilic cycle, marked irregular folding in nuclear and LCA positive. So look at these clues, you can still get an idea whether your malignancy of unknown origin is carcinoma, melanoma, or lymphoma. And sometimes there can be deceptive histologic features on lymphoma. There can be a sinusoidal infiltration. It can have a signaling appearance in DLBCL and follicular lymphoma. Spindle morphology, I told you, in ALCL, myxoid stroma, fibrillary matrix and rosette formation can also be there in lymphoma. So you have to be careful with these parts also. Like DLBCL showing a spindle morphology, DLBCL showing lots of plasma cells, DLBCL showing lot of clearing, DLBCL showing lot of sinusoidal and lymphocytic infiltration. So first you get a slide, you think whether it's a lymphoma or not, number one. Number two, is it a B cell lesion? Is the B cell lesion diffuse or follicular? Is it small cell, medium size, large cells? Are the cells pleomorphic or monomorphic? Does the B cells express cyclin D1? If not, if it's CD5 negative, is it CD10 positive? Is Ki67 very high in medium to large cell lymphoma? Check for EBV positivity because the EBV positive lymphomas. If CD10 is not negative, you will use the Hans algorithm and see whether the status of B cells is in MUM1. And in double hit lymphoma, double expressor, you look for BCL2 and CMYC positivity, and you can do FISH for diagnosing this entity. So summary is morphological stepwise approach, list of differentials. Before you start seeing the slide, and after you see the slide, again your list of differentials. ISP panel markers, positives, negatives, positive or negative. Rare variants of common lymphomas, like I told you, follicular lymphoma can have many variants. Less common lymphomas can also be in the differentials, and sometimes you need to resort to FISH and molecular studies. And before I finish my talk, again I am taking out this slide. So immunohistochemistry interpretation is very, very important. You must understand normal, cells of interest, positive or negative, appropriate setting में, where the switch marker should stay which part of the cell. Background cells are taking what stain. Controls, you should be very careful at controls. Loss of a marker or aberrant expression. No one marker is loyal to any tumor. So you can, be very judicious when you use your eyes. I conclude here, and I just hope I have not confused you more. If I have not put in a headache on you, and I hope I have relieved some of the headaches which you encounter when you deal with it. Thank you so much.
I think, sir, we all
Thank you, sir,
agree,
for-
and a lot of postgraduates will agree with me that whenever the biopsy sample is small, there is a bigger headache. Ranking among them was, I think, lymph node. I used to be terrorized in my postgraduate as a, whenever that lymph node used to come, because I had no idea what was happening there. I wish I could hear this slide, these presentation when I was a postgraduate. I'm sure a lot of postgraduates will have had a lot of information from this. I wish we could hear it more, but due to lack of time.
to hear it more in your live slide demo in the.
Yes, sir. I will be ready. Thank you, sir.
I will speak for
Questions, you can always come to me and you can approach me in one session or at the post slide, slide demo, you can ask me any question. I want the slide demo to be interactive. Okay, this was a lecture in context of time, but in the slide demo, I wish it to be more interactive from especially the videos. Thank you so much.
Dr. Chaudhary, I have to leave because I am Dr. C.P. Mishra. I am not from the Department of Community Medicine. I had been in BHU and here also. My question is, not question, it's a comment. The dictum is that don't go by authority, go by evidence. In today's era, sorry, Dr. Saab's lecture wonderful. It is a fully charged lecture. But certain evidences have to be created, particular marker. So what is the probability of that marker will present in particular condition? We need that data to derive at the conclusion. Second thing, there are many modalities of diagnosis of particular condition. Okay, morphology, genetics, and this and that. So there is a concept, test in series and test in parallel. If at one particular point, if it is positive, we'll consider it or not. Or we want positivity at in all the tests. Okay, so that test in series and test in parallel concept, we have to research into that particular area. There are 5 or 10 markers. If you write the probability of each markers, if this is present, positive predictive will be 90%. If this is present, positive predictive value will be 5%, 10%. That we have to work out. This is one comment, but your lectures of high authority. And now the dictum in research we have said very clearly, we will not go by authority, we will go by evidence. And that evidence calls for probabilities of each condition, each marker. If it is present in 10%, we will say it is no. So higher the probability, higher the positive predictive value, the clinicians will like that particular test. If a test has very low positive predictive value, they will rule out. But in certain conditions, we also will want with negative predictive value also. So that data will make it much wiser as a pathologist, as a clinician. Second one, very important question, primarily started. I will take, sir, 1 minute. That test पर हम टेस्ट को देख लें क्या रिजल्ट है, तब क्लिनिकल कोरिलेशन करें या बाद में करें? नहीं. Please think anything, any crazy idea you bring in the mind. But sometimes we get biased also. So हो सकता है कि बहुत सी conditions में is there any evidence anybody has worked out कि जहाँ पहले किया और जहाँ बाद में किया, what is the additional gain we are getting? Okay, that type of a study I want. Okay, thank you very much. And thank you very much to Dr. Neeraj, he is a very brilliant teacher of our institute. मुझे इनवाइट किया था इन्होंने पर्सनली और मैं खुद था क्योंकि मैं 1981-82 में आई वाज डीलिंग विद acute myeloid leukemia and lymphatic leukemia. It is easier to treat lymphatic leukemia. Myeloid leukemia, hardly I have seen that after a certain period of time. Survival was very poor in acute myeloid leukemia. Okay, so after 81 I got long time in Calcutta because my sir was a very brilliant person. Dr. M. Rakhet, he was a professor of medicine, but he was looking after the hematology unit, and I was senior radiologist. So we have observed that test. So we have to see that how this diagnostic thing has made a difference in the survival of the patients. Okay, that study also we need. Thank you very much.
Thank you, sir, for the enlightening and enriching talk. We are thankful to our chairperson for moderating this session.
Thank you, sir. Thank you.
We now request Dr. Zakaria sir to felicitate the chairpersons, Dr. Bismillah sir and Dr. Deepa Rahman.
Kindly request our judges for Patho Art Contest, Dr. Shivani Sindhu Ma'am, Associate Professor, MLNC Prayagraj. Colonel Dr. Neelam Ma'am, Professor, Obs and Gynae at HIMS Varanasi. Dr. Sonu Ajmani Sir, Professor and Head, Department of Physiology. Dr. Jasmine Ravi Sheikh Ma'am, Professor and Head, Department of Anatomy, to kindly proceed for judging. We call upon our chairperson, Dr. Ikshita Dhal ma'am and Dr. Ashok Singh sir for the next talk. We welcome you, sir. We welcome you, ma'am.
Dr. Ikshita Dhal ma'am is currently serving as an associate professor in the Department of Oncopathology at Tata Memorial Center and has over 65 national and international publications to her credit. We all welcome you, ma'am.
Dr. Ashok Singh sir is currently working as an associate professor, Department of Pediatrics Heritage, Varanasi. Sir has vast experience of 10 years of UG teaching and 7 years of PG teaching and 10 publications to his credit.
We now move to the next academic session and invite Dr. Shruti Mishra, ma'am, Associate Professor at the Bone Marrow Transplant and Stem Cell Research Center at IMS BHU.
We request our esteemed chairperson to kindly welcome Dr. Shruti Mishra, ma'am.
Dr. Shruti is working as an associate professor in PMT and Stem Cell Research Center at IMS She is MD Pathology from Kolkata, Medical College of Kolkata. She is a gold medalist in preventive and social medicine, and she has several publications in national and international journals. So welcome, Dr. Shruti.
Can you give me a mic, please? मैं थोड़ा सा announcement करूँ जब तक Dr. Shruti is suggested, right? I just want to announce about the forthcoming third उत्तर प्रदेश हेमेटोलॉजी ग्रुप की हम लोग की स्टेट कॉन्फ्रेंस होने जा रही है, and we have given those forms to Dr. Garima. So all those of you who want to register offline, you can register, and those who want to register online, the website name is mentioned, you can register for it. And we have still vacancies for the workshops. We are having 3 workshops, one on NGS, second is on fish, and third is on catering. So you can register for the workshop only. and it's a golden opportunity, especially for those who are from Varanasi to register. This is going to be one of the biggest hematology meet in Varanasi in the last 40 years. So I welcome, I'll invite you for that conference, and I've also requested Dr. Garima to distribute the newsletter of our Hematology Indica. So please see to it that it is circulated. And if you have any queries, I am there as the organizing chairman for the TPHG Con, and the organizing secretary, Dr. Deepa Rani, is there. You can put your queries there.
हेलो, आयुष्मान से कराना है क्या? तुरंत नहीं होगा, 1-2 दिन लगेगा, पूरा टेस्ट होगा, उसका पैसा लगेगा उसके बाद।
Good afternoon, everyone. At the outset, I would like to thank the organizer, Professor Neeraj sir, Professor Vatsala ma'am, and her and their whole team, Dr. Ila, Dr. Soumya. Thank you so much for having me here. It's a pleasure. It's my first time visiting HMIS, and I got lost midway in between, but still we managed. And I won't bore you guys much. I will just take half an hour of your time, so please don't make your slippers ready to throw at me. Just give me 30 minutes, I'll finish it off. Okay? So today I am going to talk about morphology to flow. So basically you got the idea, we are going to talk about a bit about flow cytometry basically. So before we go to flow, since my talk is about from morpho to flow, तो morphology कब करते हैं? When do you order bone marrow in hematological conditions? Whenever the patient is having any cytopenia, or you are suspecting some hematological malignancies, or there is some infections, which you need to do some cultures from the bone marrow aspirate itself. Correct? So these are the indications of doing the bone marrow studies. Now among these, where does the flow cytometry comes in? Where does it play a role? So basically it plays a role in giving you particular analysis of what is the type of leukemia that you are dealing with, what is the type of lymphoma that you are dealing with. Sometimes we also can do the MDS diagnosis. What is MDS? Myelodysplastic neoplasm. So the nomenclature has changed, but the abbreviation is still the same, MDS only. What is MRD? Can someone say the full form? No, it is not minimal. It was an old terminology where it was called minimal. Now it is measurable residual disease, whatever you can measure. So MRD detects. For MRD also we use flow cytometry and DNA ploidy and proliferation determination. Apart from this, we can also use flow for PNH, for CD34 assay and everything, but I am not going into much details of that. I will be mostly restricting to this aspect. Can we cut off the light in the back? It's distracting. So, yes. So what is flow cytometry? As the name suggests, flow means something which is in motion, flow kar raha hai. Cyto means cells, metry means measurement. So what you are doing exactly in flow cytometry, measuring the nature of the cells while it is in motion. ठीक है, static नहीं है, slides नहीं है, static नहीं है, motion में है, ठीक. So these are some instruments. This is just a short video to give you a brief idea about the whole principles and the various parts of a flow cytometer instrument per se. Okay. Okay, the audio is not that visible, so I'll just talk to accommodate that. So there are, let me start from the beginning itself. So you have this fluidics part where your sample is going to flow. Then you have the lasers or the light part. And then you have your detectors which are going to detect the lights which are being scattered. And then you have your computer system which is going to take in the data that is being coming from the photo. So once the sample is put into the instrument, then what happens? The cells are processed and mixed with some saline, and
pass through the lasers in a single film. So this is called hydrodynamic focusing. Now this feature is also there in your automated hematological analyzer. Okay. Now what happens once the cell passes in front of the laser? What will happen? There will be one type of a scattering that is called forward scatter, which will depend upon the size of the cell. So if the cell is larger, then the size of the scatter is more, or the shadow that it throws in the back detector, forward detector is more. If the size is small, it is smaller. Okay, so next what happens? There are other detectors which are in perpendicular. Now they will detect the side scatter. Now what is determining the side scatter? Now this is just a histogram which you get upon the size of the cell. If you just take one parameter and you do a plot, that will be a histogram only. Multiple parameters, you get scatter plots. Now side detectors, this will detect the side scatter. Side scatter depends upon the nature of the cell. That means complexity of the nucleus, granules, and overall size of the granules, etc. So higher the side scatter, higher the complexity of the cell. Now that can, when you combine these two together, you can get a more or less a differentiation of what type of cells you are dealing with exactly. Now till now, this is what you have in your automated hematological analyzer also. If you go back to your lab, check the scatter plot of your automated hematological analyzer, you will see scatter plots like this, which is differentiating the lymphoid cells, the monocytes, as well as the granulocytes. Okay. So that is just a brief about what is inside your flow cytometer. Okay. Now coming to the flow rate. Why flow rate is here? Because this is the basic crux which differentiates your flow cytometer from your automated hematological analyzer. Automated hematological analyzer में आप कंट्रोल नहीं कर सकते कुछ भी, आप कुछ कमांड नहीं दे सकते. Everything is set up, आपको बस samples run करना है. Here, the whole thing is under our control. How fast we want the cells to be aspirated, how much we want the sensitivity or the specificity of the flow cytometer is to be, is totally dependent on the user and what is the intended use of that particular thing. So now, this pressure that is I am showing over here is obviously the pressure of the internal column where your sample is flowing. Okay, now if the pressure is low, sheet fluid का pressure आप control नहीं कर सकते, वो automatic है. If the pressure of the sample fluid is low, then obviously the channel will be narrower. That means more single cells will be passing through it. If I increase the pressure of the sample fluid, then what happens? It becomes wider. That means more number of cells can go at a time and the aspiration rate will be faster. Now how is this differentiating the results, affecting the results? So if it is increased, naturally the flow rate increases, the number of doublets or the number of multiple cells that is passing at a time in front of the laser, chances and probability of that will increase. Okay, so if you have a flow rate, you have a lesser result but a high sensitivity. But if you have a low rate, you have a higher resolution but a low sensitivity. किसका किसमें यूज है? अगर हमको हाई सेंसिटिविटी चाहिए और लेसर रिजोल्यूशन, रूटीन फेनोटाइपिंग में, ठीक है, जिसमें हम लोग मीडियम प्रेशर रखते हैं मोस्टली. अगर हमको हाई रेजोल्यूशन चाहिए, वो हम यूज करते हैं डीएनए फ्लॉइडी वाले असेस में. Okay, so this is what we have already told that अगर whenever a cell is passing in front of the laser, जो पीछे की तरफ जो आपका diffraction होगा, that is the forward scatter and it will be detected by the forward scatter, and जो आपका cell के nucleus से deflect हो रहा है या फिर granules से deflected हो रहा है and overall cytoplasmic content से diffraction हो रहा है, that is detected by the side scatters. So what are these cells? These have the least forward scatter, that means they are the smallest in size. They have the least side scatter, that means their cytoplasm is not complex, they don't have any granules and they don't have any lobation. तो कौन से cells होंगे ये? Lymphocytes. लिखा भी है आपको. You can just read it and tell it. अरे इतना भी hypoglycemic मत हो. 115 ही हो रहा है भाई. थोड़े देख लो 5 मिनट। इसके ऊपर अगर थोड़ा सा साइज बड़ा है पर साइड स्कैटर कम है तो ऐसा सेल होगा जो साइज में बड़ा है पर कॉम्प्लेक्सिटी नहीं है, उसमें मे बी ग्रेन्युलेशन उतना नहीं है एंड लोकेशन नहीं है, तो दोज आर मोनोसाइट्स। And the cells which have got a large number of locations, a large number of granules, they will be coming up, that is the neutrophils, and the eosinophils will be coming even higher than that of neutrophils because their granules are larger and coarser. Basophils won't come that high, they will lie somewhere behind the monocytes, which you have already read in your automated hematological analyzer cube, because the granules will be overlapping each other. तो इतना लाइट का डिफ्रैक्शन का स्पेस ही नहीं रहेगा, ठीक है। एंड ये जो एंटिटी है दिस इज डेब्रिस एंड आरटीसीज और प्लेटलेट क्लम्प्स व्हिच आर द पार्ट एंड पार्सल ऑफ व्हाट यू गेट व्हेन यू आर डूइंग अ प्रोसेसिंग। कोई भी कितना भी हाईली स्किल्ड प्रोसेस करने वाला टेक्निकल स्टाफ क्यों ना हो, डेब्री रहता ही है, और डेब्री रहना एक तरह से अच्छा ही होता है, सो दैट यू नो दैट you are not missing out on your target cells. Okay, now since it is flow cytometry, what is fluorescence? What is fluorescence? Anyone can tell? Basically, it is emission. There is one molecule. If I say a molecule is having a fluorescence nature to it, what does that mean? That means whenever a light of that particular spectrum which can excite it falls on it, then that particular molecule will get excited and go to an excited state. And when it comes back to the ground state, it will release energy in the form of photons, which can be detected by our detectors. And that photons is basically fluorescence. So this is what our fluorescence dyes do basically. तो अगर ये इलेक्ट्रोमैग्नेटिक स्पेक्ट्रम देखोगे, so एक चीज बता दूं पहले से, आई नो फिजिक्स वाज वेरी बोरिंग एंड हम लोग इसीलिए सब मेडिकल फील्ड में आए हैं, बट फ्लो साइटोमेट्री जाननी है तो फिजिक्स में थोड़ा सा अपना फिर से रिवाइज करना पड़ेगा। तो क्लास 12 याद कर लीजिए फिर से, थोड़ा सा ऑप्टिक्स में क्या क्या पढ़ते थे। तो इलेक्ट्रोमैग्नेटिक स्पेक्ट्रम क्या होता है बेसिकली? विजिबल लाइट, एनी वेवलेंथ हायर देन दैट इज अल्ट्रा, any wavelength lower than that is infrared. Okay, so we have got lasers in our flow cytometer. बोला था ना ऑप्टिक्स का पार्ट है, आपका लाइट का पार्ट है, लेजर्स रहता है। तो लेजर्स में हमको जानना है कि हमारा जो फ्लोरोक्रोम है जिसको हम यूज कर रहे हैं, कौन सा लेजर उसको एक्साइट कर सकता है। ना यू कैन नॉट हैव अ एपीसी को लेके आप एक एपीसी वाला डाई लेके ब्लू लेजर से उसको एक्साइट करने की कोशिश करोगे तो वो ऑब्वियसली काम नहीं करेगा, बिकॉज दैट इज नॉट एक्साइटिंग। आपको अगर ब्लू लेजर यूज करना है तो आपको फिटसी यूज करना पड़ेगा या फिर पर्सिपी यूज करना पड़ेगा। सो यू हैव टू यूज द पर्टिकुलर अलाइंड फ्लोरोक्रोम विद द लेजर्स दैट यू हैव इन योर फ्लो साइटोमीटर. दैट्स व्हाई यू हैव टू नो व्हाट फ्लो साइटोमीटर यू आर हैविंग इन योर इंस्टीट्यूट. ओके, now this flow cytometers जब आपका photons जो release करते हैं, it is not in the same spectrum as it is getting excited. तो जिस wavelength में maybe अगर इसको blue light से laser से excite किया, जरूरी नहीं है कि वो blue spectrum में ही वो photons निकालेगा. It will be in some other spectrum. Okay, so you have to know that also while designing your panels. Now these are certain spectrums, and obviously you can see there is overlapping between the spectrums of the emission. Now this overlapping knowledge is important, which I will come to in subsequent slide. Now brightness, fluorochrome का कैसा कितना brightness हो रहा है, मतलब how bright is the light that is coming out of the fluorochrome. It depends upon two things, the quantum yield and the efficiency, and that is called the staining index. ओके, क्वांटम यील्ड और लैटिन एंड ग्रीक लग रहा है, किसी जमाने में पढ़े थे। तो बेसिकली कितना फोटोन वो निकाल रहा है, कितना लाइट वो एमिट आउट कर रहा है, ठीक है। सो दैट इज द थिंग. तो व्हाई स्टेनिंग इंडेक्स इज इंपॉर्टेंट, बिकॉज वी हैव टू नो कि हमको कितना क्वांटिटी एंटीबॉडी जो कॉन्जुगेटेड है उस पर्टिकुलर फ्लोरोक्रोम में उस सैंपल में डालना है. इफ वी ऐड टू मच ऑफ एंटीबॉडी, देन व्हाट हैपेंस, देयर इज सब ऑप्टिमल सेपरेशन. आपका नेगेटिव and आपका पॉजिटिव ऑलमोस्ट मर्ज कर रहा है, सो यू कैन नॉट डिफरेंशिएट, यू विल फॉल्सली डायग्नोज एन एंटीजन व्हिच इज नेगेटिव टू बी पॉजिटिव. If you have too little, then what happens? आपका positive negative की तरफ चला जाएगा. Maybe CD3 was positive, but you added such a little quantity of it that it never detected. ठीक है, तो false diagnosis होगा. Now, apart from fluorochromes, there is another thing called tandem dyes. क्या है? अभी आपने सुना होगा कि हमारे पहले के जमाने में 3 कलर्स होते थे, 4 कलर्स होते थे, अभी 8 कलर्स हैं, 12 कलर्स हैं, 20 कलर्स हैं. What are these colors? Crayons वाले कलर्स नहीं है obviously. These are the fluorescence वाले, fluorochromes वाले कलर्स. Now obviously हमारा base fluorochromes जितने थे पहले के जमाने में सिर्फ वो अभी भी fixed ही हैं. How are we increasing the colors? We are adding tandem dyes. That means we are conjugating two fluorochromes. What happens when you conjugate? जो पहला fluorochrome है, when you excite it with a laser, the first fluorochrome gets excited. While it's releasing its energy in the form of photons, it is exciting the tandem dye. Now this phenomena is called fluorescence resonance energy transmission. Fred. Excuse me. So इससे क्या होता है हमारा? Whenever you are using tandem dyes, हमको क्या जानना है? लेजर कौन सा यूज करेंगे डिपेंड्स अपॉन द फर्स्ट फ्लोरोक्रोम. एमिशन स्पेक्ट्रम कहां से आएगा डिपेंड्स अपॉन द टैंडेम डाई व्हिच इज अटैच्ड विद द फर्स्ट क्रोमोसोम. सो यू कैन नॉट यूज द एमिशन स्पेक्ट्रम ऑफ द प्राइमरी and मतलब fluorochrome and you cannot use the excitation of the secondary or the tandem type. Okay. Now how the histogram is created whenever a thing is excited. जैसे वो बोला गया था उस वीडियो में भी, आपके फीचर्स के हिसाब से जैसे सेल का साइज कैसे आ रहा है कैसे जा रहा है उसी हिसाब से आपका photons will be detected by the photodiodes and they will be amplified and they will be taken to the computer system and the computer system is going to generate graphs for you. Histogram is something which you see in automated hematological analyzers mainly if you are using one parameter. One parameter analysis हम लोग कौन कौन से ऐसे में करते हैं जैसे DNA प्लॉटिंग हुआ उसमें हम लोग हिस्टोग्राम यूज करते हैं. बट नॉर्मली अगर हम लोग इम्यूनोफेनोटाइपिंग कर रहे हैं we will use different plots. So what are the various plots that we have? We can use scatter plots, we can use contour plots, we can use grayscale plots or density plots. आपको कौन सा plot use करना है? There is no hard and fast rule. User के ऊपर dependent है. So ये एक और difference है. This is totally on your choice. आपको कौन सा देखने में अच्छा लग रहा है, किस चीज को कौन सा कलर देना है, totally up to you. There is no such dictum, no rules for that. Now this slide इसको आप बस ऐसे ही देख लीजिए मोटा मोटा जानने के लिए कि कब बोलेंगे पॉजिटिव कब बोलेंगे नेगेटिव. If we have two dyes and cells which are lying in the left lower corner, that means they are negative for both. If they are lying in the upper right corner, that means they are positive for both. If they are lying in the lower right corner, that means they are positive for the antigen in the x-axis. And if they are in the upper left corner, they are positive for the antigen present in the y-axis. This is totally gross. We don't say positive negative in this way. This is just for your mental reference. हम लोग strength कैसे बोलते हैं? Whether it is moderate, strong or weak depends upon the inherent normal population. If your cell of interest is showing in the same area as that of your normal population, it is moderate expression. If it is brighter than that, it is strong or bright positive. If it is dimmer than that but still positive, it is dim positive. If you now, can someone tell me what is wrong in this plot? टेलिंग है कॉमेट जैसा है. और नीचे प्लॉट में क्या हो रहा है? What is this? These cells are getting lost. है ना? नीचे की तरफ बह जा रहा है. The cells are getting lost in the axis. We are not seeing how many cells are there. So obviously there is some issue in the compensation. Now compensation is what मैंने जैसे दिखाया था आपको emission spectrum. Different fluorochromes का भी similar emission spectrum है, overlapping spectrum है. So maybe PE was positive, but since it was, but APC was negative, but since there was some overlapping, APC में जो antibody है वो positive लग रहा है आपको, पर वो actually है नहीं. तो उसमें आपको PE को APC को PE से माइनस करना पड़ेगा, तभी आपको पता चलेगा कि वो actually positive है कि negative है. So that is what is compensation all about. Now British Journal of Hematology has given us guidelines how to report immunophenotyping samples. आप लोग देख सकते थे पहले जब फ्लो साइटोमेट्री शुरू हुआ था, मतलब इम्यूनोफेनोटाइपिंग में लोग परसेंटेज में देते थे, this much percentage positive, this much percentage negative, but that actually doesn't make any sense in the final diagnosis. So guidelines के हिसाब से आपको बोलना है आपका टारगेट पॉपुलेशन का परसेंटेज कितना है, वो आप गेटिंग करके बताओगे. I will tell you in 1 or 2 cases that we discuss. फिर आपको उसी गेटेड पॉपुलेशन को डिस्क्राइब करना है कि what all antigens are being expressed on the level of intensity. I am not saying going to write in my report that my blast percentage is say for example 45 and they are saying 30% 20 positive. That doesn't make any sense. It has to be, are you going to call it CD20 positive? If it is CD20 positive, it is moderate, dim or red. That's it. Okay. Then listing in positive and percentage is not relevant. Should never be relevant. Okay. And you have to, if you have any rare events and you are quantifying it, you have to level that. Like CD34. जिसमें हम लोगों को quantification करनी पड़ती है. When you do a transplant, you have to calculate the dosage. तो आपने कितना patient से मतलब आपका donor से, it may be the patient itself in case of autologous or it can be a donor, healthy donor in case of allogenic. So you have to, when you do the apheresis and you collect the stem cells, you have to calculate how much stem cells is there in the bag. So हम लोग एक aliquot लेते हैं bag का and we do the assay and we calculate कितना CD34 viable CD34 bag में होगा. फिर patient के weight के हिसाब से CD34 infuse back किया जाता है patient को. जितना collect किया गया सब कुछ ही डाल देना होता है, ऐसा नहीं होता है. ठीक है, quantification की जरूरत होती है. तो whenever it is a rare event like CD34 is a rare event and I am going to quantify it, so I have to mention कि मैंने कौन सा mix use किया, quantification कैसे किया, full calculation हमको show करना पड़ता है. Now this was all about the basics. So अभी हमको पता कैसे चलेगा कि हम लोग कुछ जो देख रहे हैं malignancies है या नहीं है. तो obviously abnormal बोलने से पहले normal तो जानना पड़ेगा. Normal ही नहीं पता तो सब कुछ abnormal ही लगेगा ना. तो there is, I'll suggest there is a beautiful series of articles by Brento which tells us about the normal developmental patterns of various antibodies. Okay, in brief, जैसे आपको पता ही होगा CD34 is there in the precursor cells, TDT is there in the precursor stage, and gradually as the cell matures वो loss हो जाता है. CD10 भी आपके precursor stage में होते हैं, mature stage में नहीं रहता है. CD20 is lost in plasma cells. So and there are certain lineage markers also. So you have to know about that. And these are the developmental patterns. I won't go into the details because I can see you are getting hypoglycemic. So similarly, सारे lineages का ऐसे ही आपको पता मिल जाएगा वहाँ पे. This is like for myelocyte series. So आपको mono, myelo सबका मिल जाता है. तो flow cytometry ल्यूकीमिया में क्या करता है? Basically आपको बताएगा diagnosis क्या है. उसके बाद आपका काफी सारे मार्कर्स के बेसिस पे आपका prognostication होगा because we can suggest what mutations might be positive in that particular patient. Whenever chemo दिया जाता है, उसके बाद आपको remission status देखनी है, then you can also do that monitoring, that is MRD assay using flow cytometry. And अगर relapse कर रहा है patient, rather than going for molecular assay frequently, flow is much cheaper and a easier and faster option than that to monitor and keep track of your patients. Okay. Now let's just discuss a few cases. 36-year-old male, pancytopenia लेके present हुआ, bone marrow aspirates were hypercellular, blasts were 32%. Okay, what is this? है सब सो है, oil rod, है ना? Oil rod है, and ये क्या stain है? SBB, Sudan black. Okay. तो अगर हम फ्लो में जाते हैं, फर्स्ट हम लोग को प्लॉट करते हैं, वो होता है फॉरवर्ड स्कैटर का हाइट एंड एरिया को अगर देखेंगे, मैंने बोला था कि हम लोग मीडियम टू हाई प्रेशर रखते हैं, दैट मींस मोर नंबर ऑफ सेल्स कैन पास व्हेन आई एम डूइंग immunofenotyping. So I have to negate out those multiple cells from the singlets, क्योंकि मुझे एनालिसिस अल्टीमेटली सिंगल सेल्स में करनी है. मल्टीपल सेल्स जो लेजर के सामने पास हो रहे हैं उसको मुझे निकालना है. तो कैसे निकालेंगे? When multiple cells are passing out in front of the laser, what will happen? The area will increase naturally, ना? Even if the height is same, if the दोनों सेल चिपक के भी पास गए, even if the height is same, the area will increase. So if we do a forward scatter का area versus height, the one having higher height can be removed as doublets. So we will left out with what is called as singlets. तो further analysis हम लोग stream down जब करते हैं, getting करके singlets के ऊपर ही करेंगे. Then if I am doing side scatter with CD45 or side scatter with with forward scatter, this is the viability gate which you usually do to rule out the debris, which always should be there in case of your processing. तो आप अपना बैरियर कहाँ पे रख रहे हो कट ऑफ का, वो आपको जब आप पर्टिकुलर केस एनालिसिस करते हो उसी के ऊपर ही डिपेंड करता है. Then CD45 and side scatter. What happens for the blast cells? कहाँ लाई करेगा? Blast cells look somewhat like your lymphocytes, right? So the side scatter should be the minimal thing. Lymphocyte के जितना ही होना चाहिए, साइज में भी lymphocyte के जैसा ही होना चाहिए. और CD45 का एक्सप्रेशन का क्या? CD45 is usually bright in case of lymphocytes in comparison to your neutrophils. Okay, it is brighter. When you have got cells which are having similar side scatter like that of your lymphocytes, small in size, less side scatter, but a dim CD45, that means those are your target blast cells. So that is called the blast window. विंडो मतलब हम लोग उसमें गेटिंग करते हैं और उसी को ही फर्दर स्ट्रीम डाउन एनालिसिस उसी को ही करते हैं. सो दीस आर रेड हमने चूज किया है, जरूरी नहीं है आप रेड चूज करो, आपको कोई दूसरा कलर पसंद है आप उसको भी चूज कर सकते हो. दिस इज नॉट अ dictum. Okay, so if you see this red cells against CD34, they are positive for CD34, they are positive for HLA-DR and CD34, and they are also positive for CD13. Okay, this is your normal population. ग्रीन वाला जो है न्यूट्रोफिल्स है, नॉर्मल पॉपुलेशन है, नियरली सिमिलर स्ट्रेंथ में ही आ रहा है. आप लेवल देखो इसका, नियरली सिमिलर है. ठीक है. एंड दे आर पॉजिटिव फॉर CD56, they are positive for negative for CD1A, negative for CD7, and negative for CD5 and 22. Okay. Now this blast have got MPO positivity. They are negative for B markers, that is cytoplasmic CD79A, and negative for cytoplasmic CD3, which is your T lineage marker. उसके बाद आपको ये जो ग्रीन वाले जो सेल्स है, they are also quite good in number and उनका जो maturation pattern है वो normal है. तो blast है, maturing cells भी है, अच्छा खासा क्वांटिटी में है और पैटर्न ठीक है, तो क्या हो सकता है? एमपीओ पॉजिटिव है, एएमएल है, बट व्हाट टाइप आर यू एक्सपेक्टिंग? विथ मैच्योरेशन. ठीक है, तो विथ मैच्योरेशन होगा तो क्या म्यूटेशन एक्सपेक्ट करेंगे? ट्रांसलोकेशन 821. सो दिस वाज अ पेशेंट ऑफ एएमएल विथ ट्रांसलोकेशन 821, दैट इज योर RUNX1 T1 म्यूटेशन. ठीक है. I think I can skip one or two case. ये कौन सा स्टेन है बताइए? डबल एस्टर. डबल एस्टरेज किस में करते हैं? डबल एस्टरेज में ब्लू होता है तो कौन सा सेल होता है, ब्राउन होता है तो कौन सा सेल होता है? Nobody? Blue means neutrophils, myeloids. Brown means monocytes. So these are like all the blast cells are there, they are monocyte. मतलब double esterase में brown है. That means you are expecting monoblasts. And the cells are positive for 11B, 117. They are not that positive for CD34, which is usually seen in case of a monoblast. But precursor markers में आपका 117 positive है, आपका 33 है, MPO उतना भी पॉजिटिविटी है नहीं, 56 है, 64 पॉजिटिव है. So monoblastic leukemia. Now we don't write directly monoblastic leukemia in flow cytometric reports. We write AML with monocytic differentiation. बाकी का म्यूटेशन एनालिसिस करके ही उनको करना है. These are blasts. बच्चा है तो इसका ऑब्वियसली सेम वे यू टेक आउट CD45 डिम है, साइड स्कैटर लो है, CD34 पॉजिटिव है एंड 19 पॉजिटिव, 38 पॉजिटिव, 10 उतना पॉजिटिविटी नहीं है, 58 डिम, 13 33 नेगेटिव, 15 पॉजिटिव, HLA-DR पॉजिटिव, 117 नेगेटिव. So what are we suspecting in this case? Yeah, BALL. B precursor ALL. Okay. Now this case report we have published in IJLS. So this was like 23-year-old male patients came to the pulmonary medicine with 1 month history of fever, cough and shortness of breath. हमारे कंट्री में ऐसा कोई पेशेंट आता है तो क्या सोचेंगे टीबी है. तो वो चेस्ट मेडिसिन में गया था, उसको पूरा टीबी का वर्कअप करके रखे थे. फिर जब सीबीसी आया तो सीबीसी में there were blasts. So once there were blasts in the peripheral blood, they were referred to the hemat department and marrow किया तो marrow was full of blast also. Now this blast, they were positive. ये हमारा blast window है, CD45 dim, side scatter low. This blast were positive for CD33. ठीक है. This blue is our normal. These are lympho population. ठीक है. 33 positive है, 13 negative है. 117 पॉजिटिव है, 64 HLA-DR सारा दोनों नेगेटिव है. Cytoplasmic CD3 is positive. If this blue is your normal B lymphocyte, so naturally our blast cells are showing positivity for cytoplasmic CD79A and they are CD19 dim also. Okay. And MPO is negative. CD5 was positive, 7 was positive, 5 आपका dim होगा because this is your normal population. मैंने क्या बोला था, normal population से dimmer होगा लेकिन positive है तो dim positive बोलते हैं उसको. CD8 and 4 are negative, 38 is positive, 7 is positive. This is surface CD3. Surface CD3 is negative. So what was positive? Cytoplasmic CD3 positive था, surface लेकिन negative है. ठीक है. And CD20 is negative. And yeah, 10 was negative, 19 हमारा यहाँ पे 19 and 38 positive है. And this population basically it is negative for CD22 cytoplasmic and negative for TTT, negative for CD1. So where are we heading for? तो यहाँ पे हम लोगों को क्राइटेरिया जानना बहुत जरूरी है कि कब किस चीज को कौन से लिनिएज में डालेंगे. You might think that it is a mixed phenotypic acute leukemia, but it is not mixed phenotypic. Why? Because this was ATP-ALL, early ATP-ALL आपका जो with aberrant B marker expressions. Why? Because WHO says if your CD3 is positive, then नीचे का ये जो है ना disclaimers भी पढ़ना होता है, वो important होते हैं. Basically when you are doing analysis and patient आपका अगर T lineage is there, CD79A cannot be taken as a criteria for telling it to be a B lineage. तो B lineage होने के लिए हमारा क्या criteria था? 19 has to be strong. If 19 is strong, you need one more strong expression of CD10 22 और CD79A. But CD79A is positive था इसमें, 22 was negative, 10 was negative. So and CD79A we cannot consider because our cytoplasmic CD3 was positive. So this is not a mixed phenotypic acute case. This is a ETP-ALL with aberrant B expressions. Okay. Now this was our case series which was published in Cytometry B on all about ETP-ALL, where we had 2 or 3 more cases showing aberrant B expressions. We can also do MRD detection. So MRD में basically क्या होता है, आपका malignant cells हट गया, normal cells आ गए, पर एक आध जो आपके malignant cells है, they still have the propensity or possibility of going into malignancy, आपको उनको detect करना है. Molecular multicolor flow cytometry is now at par with your molecular analysis, and basically I won't go into the intricacy of this case. तो basically हम लोग क्या करते हैं, देखने के लिए 3 चीजें देखते हैं. ल्यूकीमिया एसोसिएटेड इम्यूनोफेनोटाइपिंग है कि नहीं, नॉर्मल एंटीजन से कोई डिविएशन है कि नहीं, एंड क्रॉस मार्कर एक्सप्रेशंस अगर है तो वी यूज दोस फॉर बेसिकली डिटेक्शन ऑफ योर एमआरडी. लाइक इन आवर ETP-ALL cases it was showing CD19 positive, so we can use CD19 for our MRD detection. Understood? Cross lineage expression. Like say for example आपका जो BCP-ALL है जिसमें आपका 1221 ट्रांसलोकेशन होता है, they usually have aberrant myeloid expressions. You can use those markers for doing the detection of MRD. Okay. I am not going to Euroflow में आपका panels बताया हुआ रहता है, but obviously depending upon your flow cytometer, your instrument, the number of lasers you have to design your own panel. You can use Euroflow as a guideline कि कौन सा मतलब because antibodies का भी बहुत सारे varieties है, so कौन सा यूज करना है, कौन से फ्लोरोक्रोम के साथ वो conjugated होना चाहिए. Basic rule of thumb is that if the antigen expression is high, use the dim fluorochrome. If the antigen expression is low, use the brightest fluorochrome so that you don't miss it. Okay, so that is the basic rule of thumb. Myelodysplastic syndrome हम लोग डिटेक्ट करते हैं any deviation in the normal maturation pattern देख के. And shall I discuss one case of lymphoma? Okay, ये वाला result है. Okay, this one. 42-year-old male. He presented with pancytopenia and huge splenomegaly. What is this? Projections है ना कुछ hairy cell जैसा लग रहा है ना? तो उसका जब cells को हम लोगों ने देखा तो it was CD11C positive, CD103 positive, CD25 positive, 20 positive, but 23 was negative, and 5 was negative, 22 positive, and there was a kappa restriction. Lambda was negative. So this was a case of hairy cell leukemia. We can also use flow for myeloma, which we are doing in our center. So this was the case where the patient had, you can see this plasma cells, right? This is like in the marrow, but the number of cells, this is a binucleated one. So the number of plasma cells may be low, but you can still pick it up. But the point is, problem with myeloma is whenever you are processing, you might lose out the cells in the processing. So we can say the clonality, and that this is the last slide of me. So this is, you can just say the clonality, but we can never मतलब काफी बार होता है ना जो क्राइटेरिया होता है, जैसे प्लाज्मा सेल ल्यूकीमिया बोलने के लिए होता है कि आपका परसेंटेज कट ऑफ रहता है, तो वो सब आपको may not accrue to that, but for that you have to go back to morphology. Okay. So I started my journey of flow when I was doing my fellowship in CMC Vellore, where I had to do all the CD34 assay all by myself without any technical support and all. But then this was my first publication in IJRH, and it was and that showed that I really like the instrument and how it functions basically. And we have some foreign collaborations also about rare events. How do you detect rare events? कैसे उसको बोलोगे कि आप जो कर रहे हो वो सही है कि नहीं, वो कैसे पता चलेगा? Standards होना चाहिए. So there are standards and protocols and guidelines which you have to follow sometimes. This was our flow cytometry workshop which we had conducted last year, This year also it is upcoming in April 4th and 5th. This year, if you are interested, अगर मेरे talk से आपको लग रहा है flow cytometry is something which you want to delve into further, it is a 2 full day workshop on April 4th and 5th. Follow this website for further knowledge. And also, I will take this opportunity to say that coming weekend we have a conference on artificial intelligence in healthcare and research, which we are conducting. And this is a ministry-sponsored conference. It's a 3-day thing. On day 14, you have 4 workshops, and you can choose any 2 to attend. And day 15 and 16, the conference days. You can go to the website and check out further details. Thank you so much.
Thank you, ma'am, for your very exhaustive and erudite, but giving practical information to our PGs, because I am not from a pathology background, but still I am able to understand what you are basically teaching by the method of giving examples. That is very nice of me. Thank you. Thank you so much.
Thank you, ma'am, for sharing your expertise and valuable insights. We are thankful to esteemed chairpersons, Dr. Ipsita Dhal, ma'am, and Dr. Ashok Singh, sir, for graciously chairing this session. We request Dr. Shruti Mishra, ma'am, to kindly felicitate our chairpersons, Dr. Ipsita, ma'am, and Ashok Singh, sir. We now request Dr. Soumya Pandey, ma'am, to kindly felicitate Dr. Shruti Mishra, ma'am.
Now, to one of the most awaited and exciting sessions of today's CME, the quiz session. This session will be conducted by our quiz masters, Dr. Garima Dwivedi ma'am and Dr. Akanksha ma'am. We request the quiz participants to kindly remain seated. We invite the delegates to kindly proceed for lunch. The lunch area is in the basement. We request all delegates to kindly assemble back on time as the next academic session for the post-lunch at 2 p.m. We now invite our quiz masters, Dr. Garima Dwivedi ma'am and Dr. Akanksha ma'am to kindly take over.
Make them sit according to that. Yeah, are you sitting on that order? Yes. Names wise? Tubal. एक Pathfinders, just sit here. Take the seat fast.
Please don't talk. हम भी लोग बच्चे हैं, ठीक है? So be attentive. So basically, you will get 5 marks for the correct answer, and there is no negative marking. And the person, like the team which will press the buzzer first, will get the chance. So be
Lights on कर दो. Lights on कर दो. अमृता, बजट की आवाज तभी आएगी जब टेबल पे रहेगा वो, ठीक है?
नहीं, एक मिनट. PGs, you will see, you will see that who is pressing the buzzer first. ठीक है? Amrita, Matra, all PGs, please be attentive.
Hey, listen.
Now we'll make this.
All of you are sitting in the.
No, we'll make this a bit funny. So, all PGs will get allotted on one group. Neetu, you are from your group is team 1. Team 1 is Priya, team 1. ठीक है? Neetu, Amrita, team 6. सौम्या, एक कौन सा टीम है? टीम 3 है ना? 3. तुम्हारा?
फेवरेटिज्म हो रहा है.
अरे कैसे जाना है ऐसे?
They have to finish before they come. ठीक है? PGs will not give a clue or answer.
Just see, अभी आंसर कलर नहीं देना. First we are pressing the buzzer, फिर हमें पता चलेगा which team is there. ठीक है? And then वो नहीं किया तो फिर we'll pass. चलो. First.
लाइव चल रहा है?
वही तो कर रहा हूँ मैं, सारा दिखाना
नहीं चल रहा.
चल रहा है.
Please, yes, starting, no talking. Loss will be yours.
So, 26 year old boy. So, answer दो. क्यों है आंसर सी? चलो बताओ. क्यों है ह्यूमैनिटी? आंसर का आंसर.
wrong answers? No, talk on the morphology. This is pathology.
This time we are getting point, but आगे से नहीं मिलेगा. You have to be reasonable because question अभी पढ़ा नहीं है and you are telling the answer. So don't be so smart and so fast. ठीक है? You need to answer क्यों है ऐसा. So basically, if you see there is a pallor means anemia है plus jaundice. If there is pallor, jaundice and splenomegaly, and if you see these are the white cells or histiocyte-like cells, so you will think of hemolytic anemia. So we are more smart than you. So don't try to be over smart.
Listen, until the question doesn't get over, like all of you have to see the
Yeah,
question
sure.
properly and then analyze and then press the buzzer. Not like, the minute we pass on, you're not supposed to press the buzzer like that, okay?
Be careful.
Ma'am,
+5 to Team Phoenix. Yes.
Okay, the second question is,
Please leave the question. No, we can.
you have to answer. Listen to the question first. Identify the disease based on the chromosomal abnormality. Okay, then CML. Which answer? CML. Okay.
Why
Why?
CML? 9/11.
What happens?
मैम एक ऐसा रूल कर रहे हैं क्वेश्चन आप रीड करें उसके बाद ही बदल
पहले क्वेश्चन रीड करने दो फिर बजर बजाओ. क्वेश्चन डिस्प्ले होते ही बजर नहीं बजाना है.
That means the question is leaked by either Pranjal or Muskan.
Ma'am, I did not see the question, ma'am. He was answering the question.
मैम
This is not possible. Question से you're not seeing an answer.
मजाक किया भाई मजाक.
मैम मैंने कुछ नहीं किया है.
We'll read question and then we'll say
That's
start.
an impromptu question for me.
After we say start, either of us will say start. After we say start, you have to press the button.
इससे पहले इसमें दबाया उसका माइनस होगा.
Be careful. Aditya, yes.
Otherwise, Sarima, we will ask impromptu questions.
ये करना है मैम +1 इनका +5 करना है.
So this 65-year-old man presented with bone pain, fatigue, recurrent infection. Okay. So actually there is punch out lytic lesion. So if you see there is calcium is elevated.
माइनस मैम 3 टीम का माइनस होगा मैम 3 टीम का.
I will please one side say, okay. So old age, calcium elevated, renal failure, anemia, bone lytic lesions.
अरे स्टार्ट नहीं बोला है मैम ने भाई तुम लोग क्या हो भाई.
Start or I say
Should we pause the question?
start.
You pause.
Are you mentally
मुस्कान मुस्कान
इसकी आवाज क्यों नहीं आ रही? मैम वो लोग वेट ही नहीं कर रहे वो लोग.
What is this one?
जो फीचर्स के अकॉर्डिंग है उसके साथ है.
क्या फीचर्स हैं?
कैल्शियम एलिमेंट कैमरे का नाम.
अब फोर्थ क्वेश्चन रीड करने चाहिए डॉक्टर कांचन. पहले तो आप बजर नहीं प्रेस करोगे. की पॉइंट नहीं क्या है सब लोग बच्चों का हाथ खड़े कर रहे हैं. Let us finish. I say start and then you have to answer. ठीक है? आंसर में रीजन होना चाहिए. Without reason नहीं.
So it's a 35-year-old female, fever, splenomegaly, increase in the ESR, C-reactive protein and LDH. There was a painless lymphadenopathy. Bone marrow image shows this finding. So identify the cell and tell me the disease now.
Start.
First, identify the disease.
मुस्कान मुस्कान
So I asked him actually identify the disease and tell me the cells. So he's able to say both.
अच्छा आप चलो आप लोग इसको फिश मार्केट कर रहे हो तो अब सबको हम लोग एक ही क्वेश्चन देंगे ठीक है तो अभी तक जितने हैं मार्क्स ठीक है 3
Next question.
So 35-year-old man in the endemic area presented with fever, painful lymphadenopathy, lymphangitis, and examination at night shows this on the peripheral sphere. This organism.
No
बेल -5 कर दो किसने बजाया बेल नहीं बजाने बोला है तो बेल बजाने के लिए बोला नहीं गया है पर टीम को एक क्वेश्चन वो दे रहे हैं
No, we don't have to press. We don't have to press.
मैम तो नेगेटिव करना है
Everybody will get. ठीक है चलो
मैम दे दिया मैम इनका घटाना है कि नहीं हटाना है
इनको नहीं माइनस नहीं करना है अभी माइनस नहीं करो अभी
Group B. It will go to the next group. Next question. So it's a 25-year-old patient presents with fatigue, fever, gum bleeding, and multiple petechiae associated with severe bleeding and DIC. What is the most probable diagnosis?
Ma'am, it's ABL M5 and M4 is also involved in it.
Most
ABL M5 is the
pass.
Pass. Next. See, just read this most strongly.
Akansha she said 4. Chalo next.
Yes, that's the correct answer. So M4 and M5 is also associated with gum bleeding, but bleeding and DIC. So DIC, the most common thing is AML and M3. Okay.
अब ये तो पता ही होगा हाँ 3 कौन सा है ये वाला
टीम 3
ठीक है patient presented to hospital with CBC finding of pancytopenia. No improvement is seen after transfusion. Patient is advised bone marrow aspiration and biopsy.
So what do you do? This is done for bone marrow aspiration. And what do you see? Why do you do bone marrow examination? It's aspiration or biopsy?
Fine biopsy.
No, it's the aspiration or biopsy. Again.
Biopsy.
No problem. Okay, next question.
Why is given to them?
Okay, question number 8 to the group 1, 2, 3, 4 group. It's a child eats mud, clay, and complains of weakness and pallor. What is the hematological disorder you most commonly associated with such condition? Wrong. Pass to the next group.
टीम 5
Ma'am, yes. Wait. Your number is 6 or 5? Yes, wait. 5.
Pica related to iron deficiency.
Yes, that's the correct answer.
Very good. चलो अभी तुम्हारे चांस नहीं है ना
टीम अरे हाँ उन्हीं का
identify the person.
See, this you should be able to answer. This was in today's lecture. Not you. Group number. Yes, that's the correct answer. Who is he? He's father of?
फाइव
Most bequeathed आपका
टीम 6
Question number 10. A 62-year-old man presents with back pain, weakness, and recurrent infections. Diagram next below. On heating of question number. Urine on heating at 50 degrees Celsius, there is a precipitate and that disappears on boiling and reappears again on cooling. So what is the most likely diagnosis based on test morphology and everything?
हाँ क्या हो रहा है ये क्या?
50 degrees Celsius in multiple myeloma precipitation occurs. That is why
क्या होता है? और क्या यहाँ क्या दिखेगा?
Ma'am, extra. Can I answer it correctly?
Don't fight.
मैं बोला ना
आपस में देना है हाँ हाँ
12-year-old child presented with recurrent jaundice since early childhood, parallel and positive family history of similar illness.
इसमें है ना ये उसका ब्लड पिक्चर है, ये टेस्ट किया है, ये ग्राफ आया है, क्या हो सकता है?
Fast. नहीं इसका है ना Fast. I'll count till 5. 1, 2, 3, 4, 5. Wrong.
पास पास
अरे पास हो रहा है
1, 2, 3, 4, 5. Next. Wrong.
भाई टीम 3 होगा ना
अरे तो पास अब ये टीम को ही मिलेगा वो फेल होगा तो आउट को मिलेगा मैम 2 मिनट हो गया 2 मिनट का टाइम था खाने का
Okay, next question.
50-year-old man presented with sepsis, developed bleeding after IV set, lab reports platelet low, PT, APTT increase, D-dimer increase. तो क्या है?
मैम सेकंड टीम 2
Out 4, 5. बोलो नहीं.
अरे मैम टीम 3 को मिलेगा टीम
3. What is the full form of
मैम इनको दे देना पॉइंट
Okay, next question. Question number 13. The second last question. Patient with anemia has a pallor, frontal balding, maxillary hypertrophy. Reveals transfusion dependence, but the multiple transfusion underlying pathology is due to. Do we have a picture for this? Next.
क्यों क्या हो रहा है हाँ वो नहीं बता दिया इसको पॉइंट दे देना ये ये वाली तुम्हारा हो गया अब इन लोग के लिए भी एटलीस्ट ना फॉर दैट हो गया इसको भी दे देना हाँ दे देना
And no question. Two questions random.
इसके लिए आपका 5 and 6 ठीक है मेरा 5 के लिए अरे मजाक था भाई बेचारे को लगा नहीं लिख हुआ है
मैम सच
लेकिन कोई है ही ना लिख करो इसको हम तो कैमरा देखते हैं आई वाज नॉट लुकिंग
मैम आई वाज आल्सो नॉट लुकिंग क्वेश्चन लिख ही नहीं हुआ एक भी
अरे तुम्हारी आवाज जा रही लाइव में
तो क्या गाने दो
ठीक है भाई अच्छा अब ये बताओ
ठीक है this question अभी तुम लोगों को फोटो दिखाएगा ध्यान से सुनना so there is a 12-year-old girl she is presented with acute severe chest pain with chest pain she was anemic and jaundice
and but spleen was normal for her. There was no splenomegaly, or you can say there was some infarct in spleen. So it was one of a hemolytic anemia. So what could be it? There is acute chest pain, there is no splenomegaly, and then there is anemia. Options we give now. We give options.
Now,
It's a hemolytic anemia. Okay, so first option is your thalassemia, hereditary sideroblastic anemia, then you have sickle cell anemia and hereditary eleptocytosis. चलो बताओ. Hereditary eleptocytosis. So ध्यान से सुनना because we don't have there no.
चलो तुम बताओ. ए बोलो.
Six variety करो बताओ. ठीक है? Well, thalassemia, hereditary spherocytosis, sickle cell anemia, hereditary eleptocytosis. Fever है, chest pain history है, anemia है, jaundice है, but no spleen. Hemolytic anemia है, spleen is normal. गलत.
टीम 1 को मिलेगा मैम.
हाँ, sickle cell.
Just one more question.
Chance मिलता है बेटा तो आंसर करना होता है ना.
हाँ, तो that's why we are giving you the chance. This
We are
question
paying
is
you
very
question
crucial.
also ना. We had a different frame कि हम लोग कैसे कन्वर्ट कराएंगे, but then it got confused, so we gave this everyone to
You should have had the right.
अब last question for them Akansha, for them. 6 के लिए कुछ क्वेश्चन बोलो.
Okay, filaria was one of the hemoparasite. Name 2 more hemoparasite, the blood parasite.
दो बताओ.
We will count 5, okay? Because we have lunch break and then we have the other session also.
Blood parasite बोलो यार.
Anybody else? Filaria is one of the type of hemoparasite. Hemoparasite is nothing but a blood parasite. Name some 2 more blood parasites. Okay? Yes. Most common. Plasmodium what? Plasmodium species, yes.
+5.
मैम देयर इज अ टाई बिटवीन ट्यूमर एंड बिना तो मैम अपना क्लियरली डेड सीरियस है.
ठीक है. अब टाई ब्रेकर है.
टाई ब्रेकर होगा टीम नंबर 1 यानी ट्यूमर नर्ड्स और टीम फिनिक्स के बीच में.
तो सबसे क्या आप लगा?
मैं फर्स्ट एंड थर्ड नहीं था लाइक
Actually, question. Hey, Tito, you had a question extra वाला बता.
मैम फर्स्ट सेकंड करना है सेकंड.
फर्स्ट सेकंड. हाँ.
फर्स्ट सेकंड तो
फर्स्ट तो ये है तुम्हारा.
फर्स्ट तो ये है.
Okay, we'll ask you some markers.
मैम कभी बाकी टीम तो पे.
Right, some markers.
ओह
इसके बीच में है.
1 and 6.
1 and 6 अब बदल तुम लोग नहीं, अब तुम लोग बदल दोनों में कोई बदल.
पहले ही बता देना ताकि पहले एलिमिनेट हो जाओ.
Listen to the question.
45-year-old women presented with easy bruising, recurrent nosebleed. ठीक है? 45 year female है जिसको recurrent bleed हो रहा है nosebleed and easy bruising. ठीक है? So lab investigation showed increased APTT and mixing test was done and APTT was corrected with the normal plasma. तो क्या हो सकता है?
ऑप्शंस.
Actually, vitamin K deficiency, factor.
Listen to the question.
ऑप्शंस तो आपने सुने ही नहीं. -5.
Factor deficiency, vitamin K deficiency, platelet dysfunction, and presence of lupus anticoagulant. तो APTT increase था, mixing test हुआ, उसमें पेशेंट को normal plasma, पेशेंट का plasma normal से mix किया, and APTT correct हो गया.
अरे बाप रे.
45-year-old female है जो कि easy bruising and nose bleed के साथ present थी. ठीक है? अब इसका lab investigation कराया तो APTT increase था. पहला चीज मिला. Then there is a test called mixing test. Mixing test किया, इसको normal plasma के साथ mix किया तो एबीटीटी करेक्ट हो गया, ठीक है। अब मेरे पास ऑप्शंस क्या है, फैक्टर डिफिशियंसी, प्लेटलेट डिसफंक्शन, प्रेजेंस ऑफ लूपस एंटीकोएगुलेंट एंड विटामिन के डिफिशियंसी।
टीम फिनिक्स।
Be there in the regulatory time that will be given the moment for the certificate.
हमारा तो कैसी है, एक से गैस मारा है, पर फैक्टर डिफिशियंसी हो रही है, तो कैसे करेक्ट हो गया, क्योंकि नॉर्मल प्लाज्मा जब लगे मिलेगा तो पेशेंट के नॉर्मल प्लाज्मा में यू हैव ऑल द फैक्टर्स, तो जब नॉर्मल प्लाज्मा किया तो एबीटीटी करेक्ट हो गया, बिकॉज एबीटीटी में हमारे कौन से फैक्टर्स की डिफिशियंसी होती है? विनर बता दिया ना आपका, विनर कौन है?
Winners बता दो।
Ma'am, Dead Serious is the winner
Okay, congratulations.
and Team Phoenix is second. Team Phoenix is second.
All of you will be getting, all the participants will be getting an e-certificate of participation appreciation, and the winners and the runner-up will be getting the memento with the certificate at 5:30 at the end.
तालियां बजाइए भाई। हाँ। एक बार हमारे क्विज मास्टर्स के लिए थोड़ी तालियां बजाइए। नहीं सुना क्विज मास्टर। सबसे पहले तो ऑडियंस की होनी चाहिए।
एक उसका फोटो लो तो इसमें तो इजी है।
मैम आपकी आवाज आ रही है लाइव। सबसे बड़ा स्कोरर था। प्रांजल पॉज करना होगा उसको। पॉज पॉज। सेकंड हाफ का तो भी करना होगा ना, तो इसलिए पॉज करने कह रहे हैं।
ये सर्टिफिकेट्स पे अभी नाम लिख के देना है क्या?
अरे यार तुम लाइव फिनिश। रुक जाओ रुक जाओ रुक जाओ, दो हाफ में करना है तो फिर स्टॉप करना होगा।
तो स्टॉप कर देते हैं।
हाँ हाँ हाँ।